Can everybody hear me, or is there any difficulties with the voice? Sorry.
Assalamu alaikum. Yes, we can hear you very clearly.
Walaikum assalam. Thank you so much. I think we're just waiting for the host, and then inshallah, after introductions, we'll get started.
I am here. I'm so sorry.
Sorry,
There was
no
a
problem.
connectivity issue at my end. Assalamu alaikum. I'm Falaha, the moderator for this session. I'll be introducing today's workshop facilitator, Mr. Zabair Hussain. He's a cognitive behavioral psychotherapist and a clinical lead and service manager. He has lectured at various universities and worked in both NHS and private sectors. He has completed a BS degree in psychology from Manchester and has done his MS in qualitative psychology and health at the University of Leeds. His main focus of interest is adapting the CBT model to make it more culturally compatible and working with complex trauma. Apart from this, he has also contributed to mental health projects running in Iraq and Pakistan, and he does provide supervision too. He has been trained in ACT and CBT for long-term health conditions as well. I welcome you, Mr. Zabair, and you can start with your presentation.
Brilliant. Thank you so much for the kind introduction, and welcome to everybody attending. Thank you so much for attending today. I really appreciate this, and thank you for the opportunity for allowing me to present as well. So I guess as the host has told you a bit about myself, so my main work, I'm based in the UK, and my main work is of course around CBT and delivering CBT to mild and moderate depression and anxiety cases, but also more complex cases as well, where there's disordered eating and where there might be more complex presentation. And often in CBT, we focus on depression, anxiety disorders such as trauma, social anxiety and whatnot, but there's been little attention on CBT for eating disorders or disordered eating. So this is why I thought it might be particularly helpful to deliver this workshop. We have 3 hours today, and inshallah, I will try my best to stick to the time, but I know that can be challenging sometimes. I tend to talk a lot, so I hope everybody does not fall asleep. I'll try my best to keep this workshop as interactive as possible as well. Please feel free to take yourself off mute. Feel free to turn on your cameras as well, because it's particularly helpful to see if, for me to see if anybody has any questions, any concerns. And please feel free to speak, ask any questions as well. The more interactive this is, the more beneficial it will be for all of you as well. Of course, I will leave some time at the end for any questions, any queries you might have about this particular model or approach as well. But really, I want this to be as valuable for you all attending, and I really want you to gain as much as possible. I will also give my contact details at the end of the session as well, so feel free to drop me any message or drop me a call as well if you require further advice or even supervision around such cases around disordered eating as well. Of course, use the chat function as well. If you have any questions, I will try my best to keep an eye out for any questions or any queries which you may have during the session as well. But like I mentioned, I will try to make it as interactive as possible so you can all gain from the session, and it's an engaging session, inshallah, as well. So I'll start off with some background around this particular approach. I'll just share my screen first of all. Could I please just check if you can see the screen, if the presentation is showing now? If anyone could just let me know or drop me a message in the chat box, please.
Yes, we can see the screen.
Fantastic, excellent, thank you so much. So I'll give some background in terms of how this approach was developed, why this approach was developed as well, and also provide some information around how it's slightly different from the traditional CBT approach. So I'm hoping everybody attending today has some knowledge, background, and understanding of CBT, because most of the approaches being implemented in this model are the traditional CBT approaches, such as cognitive restructuring, behavioral experiments. All those interventions will be used in this particular approach. And the learning objectives today for this session are understanding that briefer therapies can be as effective as long-term therapies as well. So often there's been this tradition where more complex cases require more longer-term therapy. And I hope to break that myth today and break that understanding, and hopefully develop that understanding that brief therapies can be just as effective. So as the title suggests, is CBT-T. The T just stands for 10. There's nothing special about the wording over there. It's a 10-session model for disordered eating, and it's looking at how we can deliver treatment within 10 sessions. So the session also looks at understanding the structure of CBT-T, helping you and guiding you through the process and through the sessions, and what each session should involve, and how to be flexible in the delivery of the protocol. Hopefully by the end of today, you will be understanding the principles and practices driving effective change, and really looking at behavioral change, not just cognitive change in the patient, but really looking at behavioral changes and how to drive maximum behavioral changes in the patient as well in the short amount of time you may have with that client. And then of course, being able to address non-underweight eating disorders effectively in a shorter amount of time. So when I speak of disordered eating, this is the first discussion we're going to have, is looking at what we mean by disordered eating. So as a group, what I would like us to do is, if we could all spend maybe 5-10 minutes looking at some of these points, and it'll be really helpful for me to get feedback from you all, so I can hear a bit about the cases that you may have experienced and your current understanding as well. Because if I have your current understanding of this particular patient group, it'll be really helpful for me to maybe personalize the session a bit better so it meets your needs. And also it will give me an insight how you are currently treating patients who present with such difficulties, and also what protocols you're using. So if we just spend 5-10 minutes on this, please. Please, anybody feel free to speak out and address any of these points. It'd be really good if you could share your experiences. Just to reiterate, of course, anything discussed in the session, of course, it remains confidential. If you have particular cases that are coming to mind, please use anonymous names for those patients to, of course, to protect their confidentiality and psychological safety, of course. There's no judgment here on you as a therapist or as a professional. It's just developing an understanding in terms of what is currently being used in Pakistan, how current cases are being managed, and how this presents, how you've seen disordered eating in some of the patients that you have been treating or assessing in clinic as well. So please, if anyone would like to go first, I'll be really, really grateful if I could hear some of your experiences so far. And this is usually the time everybody falls silent. Nobody speaks first.
Assalamu alaikum, sir. May I share my experience?
Of course, yes, please. Please, I'm sorry, I can't see your name. Aapka naam, sorry.
Mera naam Shahida hai. I'm Shahida.
Okay. Assalamu alaikum, Shahida. Yes, please do share your experience.
You know, I am seeing one client. She has multiple disorders, but the dominant feature was the eating disorder. What she is doing is that she is not eating at all, and all the time she is worried about, I will gain weight. And in that process, when she came to me, she was undernourishment and she had panic attack. So the psychiatrist referred to me for therapy. So I think I have conducted I didn't start with the CBT earlier, but yes, I worked with psychotherapy, with different therapies, with the Gestalt approach and other. But now I've started with psychotherapy, CBT now. But that is why I'm very much interested in this workshop. Back and forth, all the time. She is so thin, and every week when she comes to a session in the hospital, all the time she checks her weight there, and she is about, I think, her, she is and she put so much makeup on her face, and she is very thin. Her like arms are very thin, and mostly, she wears a Western. She doesn't like Pakistani dresses, so mostly she wears Western clothes, and she has a lot of pressure from his father and from mother, to wear on, like Pakistani shalwar kameez. Besides that, she is also studying IT. She has done masters from, a very good institution from Rawalpindi that is called NERST, and still she is doing. I think in a week or so she is going to do her defense for that. So, but she doesn't. And for if sometimes we talk about, like these days when we are talking about after, like you start writing about what are you eating. So you make your diet chart, and she comes to me with a diet chart. So I'm unable to convince her, that you have to have a balance, some calories or something like this. So I am still struggling with her. This is my problem. This is, I feel it, that is why, I prefer to, attend this workshop.
Brilliant. Thank you so much for sharing that, Shahida. I really respect and appreciate that. So my understanding is that she's very underweight. She was referred to you from the psychiatrist. You initially approached the psychotherapy kind of approach, and now trying to introduce the CBT approach. But
with the dialectical therapy, I started with the dialectical therapy for the DC eating disorder, but now I'm working with CBT now.
With CBT. So in total, how many sessions? Takriban, like
I think 25, all together 25.
And
as it is written that what is the provision of treatment, that all the time she's so much conscious that my face has become very chubby. My her arms are so thin, that होता है ना, एक reality होती है और एक like something is like अपनी एक तो अपनी reality होती है, एक that is something that she has made her own reality like this, यानी कि ना तो वो उसको reality नजर आती है. So what and so all the time she's thinking about कि मैं मोटी हो जाऊंगी, whereas she is not at all मोटी at all, यानी कि ना face भी is very chubby and very thin, बिल्कुल उसके ना अंदर गए हुए हैं यानी कि cheeks
बिल्कुल. So मतलब it would be fair to say कि obsessional fear है that I will gain weight. There's obsession with how am I looking, my face, my features, really checking this. कितना मोटा हो गया चेहरा, कितना जैसे बंदा नजर आ रहा है.
And in addition to that, I would like to add, all the time she is like, so suspicious that everybody is looking at my plate that I am eating a lot. This is also,
So in terms of the obsessions, they manifest in different areas. एक तो मतलब उसके अपने जो features हैं. दूसरी चीज ये मैं कितनी खा रही हूँ, लोग मुझे देख रहे हैं, the worry of judgment.
मैंने कितना portion लिया, exactly. And one thing more, what she does, that she wakes up early in the morning and she comes to kitchen, she prepares her breakfast, and when I ask what have you made, so she says I have made paratha, never she looks like that she has eaten paratha, that I made it my own, and she doesn't want she wants to eat alone, she never would like to prefer to eat on the table, father, mother, and one more sister there, or she keeps herself mostly isolated to her room.
Has she eaten in front of you, by the way?
No, not at all. अभी तक नहीं. अभी have not.
नहीं. And just wondering, आपने offer किया है कि मेरे सामने आप कुछ खाएं क्या?
नहीं, never. No, नहीं. I've not yet. बिल्कुल भी. Idea भी नहीं आया मुझे तो इस बात का.
No, any reason? I was just wondering, any reason?
I only drink water रखती हूँ मैं. Water जरूर होता है, tissue box होता है, but ये नहीं होता because
हर therapy कमरे में लाजमी tissue का एक box शामिल होता है. No, that's fine. Thank you so much for sharing, Shahida, because this is really helpful to hear. I think this is pretty typical presentation in such cases. She's telling you that she's having the paratha, लेकिन जैसे आप मुझे बता रही हैं नजर नहीं आता पेशेंट में कि वाकई उन्होंने कोई न्यूट्रिशियस खाना लिया है, because the weight seems very underweight, staying withdrawn, not eating with the family, very conscious about how much she's eating. So I'm just wondering that आगे आपने क्या सोचा है? What are your thoughts in terms of what to do next?
अभी तो I'm working on कि now you make eating chart, what you do, what you eat. This last week when I had a session, So you write, because, I given a date, time, breakfast, how much intervals you have, and make it honestly. And
honestly,
this is what
yeah,
I have said to her this time.
absolutely fantastic. But much of that, it sounds like she's engaging, attending every session. जैसे आपने बताया DBT भी किया है 25 sessions तकरीबन हो रहे. She's engaged, right? So it sounds like a good relationship between you and her.
Very good therapeutic relationship. She has other issues also, because not only the eating sort of things, she has a certain problem with brother, sister.
Yes.
And so every time when she comes with her own problem, because CBT is such a structured program, when I come to a eating disorder, then up now wholly solely I had to focus on eating disorder and rest whatever she wants to share about it. So this I have started just now. This is my, I think, second session about eating. You make up like sort of, as we used to know, make behavior activation plan. I asked her to make, about that eating chart.
Yes, yes. Good, good. This is really good to hear that you're focusing on the food now and the nutrition now. And this is, again, really typical in many of the eating disorder patients. There's lots of comorbidities. There might be trauma, there might be social anxiety, depression, anxiety, many, many comorbidities. And in this particular protocol, we are just purely focusing on the relationship between the food and the behavior. Initially, we're looking at that link between how we think about food, how we think about self-image, and the behavior behind it as well. We're not addressing the comorbidities. Usually, if the treatment's successful, the comorbidities often reduce themselves. But inshallah, I will talk about this in more focus, and it's really helpful we brought this case because we can come back to this case as well when we proceed in the session. But thank you so much, Shahida. That's really useful. Any other person who would like to share their experience or particular difficulties they've had in clinic so far? Walaikum salam.
I'm Dr. Tehkisha Aruj, and I have seen the cases where selfie-taking behavior is also co-occurring with the eating problems. And my students have also done different research work on this area. And we have found that in Pakistani population, the eating patterns are changing day by day. And mostly the adolescents and the adults, young adults and the late adults, all of them are very much, you can say, worried about their BMI, about their body appearance, and they are changing their food patterns from the routine food patterns. Now they are more towards, you can say, the barbecues, the burgers, and the chips, and they are more taking them, consuming them, and the more they are taking their selfies and seeing how much I have taken and how is it appearing on my body now. Secondly, these cases I have taken, the clinical cases I have taken, selfie taking behavior was there also, and the other thing that was seen by me was the nocturnal eating patterns. So, because of the COVID, now this is the new thing that I am wondering that inshallah the DSM-5 next version will take the nocturnal eating disorder as a new disorder in the eating disorders pattern. Like the students, the businessmen, the housewives, everyone was waking up in the COVID-19 pandemic. And this was the time when the deliveries were given at the homes, and the business of delivery was at the boom at that time. And now still it is like online, we can take many things, we can purchase many things till now. And so this was very easy. And the different hotels, they are the delivery systems were very late open in the late evenings. So this is again a new thing that I have come across. But what I preferred in my treatment sessions were the CBT. And it was really very workful. And I also try to teach my students to supervise their sessions in the time that it is the best treatment strategy. Thank you.
Fantastic. Masha, thank you so much, Dr. Kehkashan, for sharing this. I completely agree. So one of the reasons why this model was created was because of the demand. So as you can all see, and this is unfortunate, not just in Pakistan, it's all over the world, social media culture. So everybody is taking the Instagram pictures. There's this idea of the perfect body, perfect face, perfect body shape. There's so much pressure in the youths, adolescents now, even adults now, that we need to look slim. Our bodies need to be absolutely perfect. Even if I was just to ask now, if we could take a poll of how many people in this room right now are happy with their body image, mostly 99% will say they're not happy with their body image. We have this social media perception that we need to look absolutely perfect. The men need to be very toned and muscular, and the women need to be very slim as well. And of course, as you mentioned eloquently with regards to the selfie taken, the filters, even the filters that have been created, encourage this, because when you use filters on whether Instagram or Snapchat, they make the face look much more thinner. And this is the message this is given to the new generation and the younger generation, is that you need to look perfect. So one of the reasons why there's more increase in disordered eating and the fear of gaining weight is social media. Social media plays such a big part, and I'm so pleased to hear that, alhamdulillah, you've done the research, you've done the studies to support this. And of course, eating patterns and behaviors have changed rapidly. And again, not just in Pakistan, this is globally as well. How people eat, when people eat, the access to certain food as well. You've got delivery services now, you've got apps which can deliver food. And unfortunately, it's highly unhealthy food. You've got burgers, you've got pizzas. And of course, because we're living in such a busy world, everybody's working, there's no time to cook healthy meals from scratch. Everybody is eating, looking for fast food. And I guess this is the world we're living in. People are looking for quick results. It's the instant gratification. I need to be slim as quick as possible. I need to be toned and muscular as quick as possible. I need to lose weight as quick as possible. I need to cook my food as quick as possible. Everything is so fast and people want instant results. And I think this is some of the difficulties we face as therapists in therapy, that therapy takes time. We're living in a world where everybody wants quick results and fast results as well. And this is something we have to demonstrate to patients as well, to stay engaged, because therapy will take time, but it's equally rewarding. But I think this is really useful, which you have mentioned there, in terms of changes in timing, eating patterns and behaviors, and the types of food that we eat as well. And this takes me on to the next part. Thank you, first of all, for sharing that the current difficulties. So I'm going to share some experiences we have in England, is that at the moment, priority is only given to the extreme underweight cases. So when we're thinking about disordered eating, there's many forms of disordered eating: restricting, there's overeating, binge eating, there's some purging behaviors. There's the eating disorders which do not fall into the full diagnostic category of anorexia nervosa or bulimia nervosa. There's many, many types of disordered eating which fall outside those categories. And because they fall outside the diagnostic criteria, it's very difficult as to which service or which support or which kind of treatment to offer that client. So the current difficulties in England is that there's very, very long waiting list. As mentioned, the priority is given to those who are severely underweight. And of course, we have to give priority to them because there's high levels of fatality and mortality. Unfortunately, there's high risk in those patients that they may pass away because they're that underweight and that undernourished. So all the priority is given to the extreme underweight cases. Long waiting lists, so often accessing therapy through the NHS National Health Service, it can take 18 to 24 months. So accessing CBT, 18 to 24 months in some services. And of course, if we can treat them quicker, the more patients we can see. If we're spending 30, 40, 50 sessions, that will stop the amount of new patients coming in as well. The second issue is they're not serious enough for admission. So many of these cases, there may be strong behaviors and strong characteristics and a very strong presentation of disordered eating, but not serious enough for admission. So they may not be behind or below their BMI or not thin enough or not severe enough to actually warrant hospital admission. As we just mentioned, social media influences as well. It's, we have TikTok, we have Snapchat, we have Instagram, we have Facebook, so much pressure now, especially for the younger generation to look in a certain way and have their body in a certain way. Most of the interventions and most of the research has focused on obesity. So when you look at the like World Health Organization or other global organizations focusing on whether that's mental health or physical health, there's been a lot of emphasis on obesity. And that's because obesity, of course, is connected to cardiovascular diseases, heart diseases, diabetes, many other complications around physical health problems. So the focus has been on obesity, not so much on disordered eating or eating disorders. So this is why, again, we need to focus on this as therapists. And then looking at the somatization of symptoms as well. So often I've seen, especially with my Pakistani and Indian patients, they may have difficulties around disordered eating due to psychological difficulties, such as overestimation of their body size or a very unhealthy relationship they have with their food. But the reason for this, they will often say it's gastro issues, or I have some issue with my stomach, I have some issue with my bowel, and they will not accept a psychological reason for their eating disorder. They will prefer a physical reason for their disordered eating. So often I have many patients who will tell me कि जैसे मैदे का मसला है या मेरे पेट में दर्द रहता है इसलिए मैं खा नहीं सकता, and these kind of issues, they look at the more medical physical issues rather than psychological difficulties associated with disordered eating. And then of course there's underreporting, especially in males. I think all the data, if you check out all the data at the moment, it's mostly females are higher reporting. And of course, again, due to societal issues and difficulties, males tend to underreport issues around eating, issues, just overall mental health difficulties as well. There's always underreporting in males. And the case study I will be using on purpose is a male, because I think there's still a lot of stigma, taboo, and a lot of cultural and societal pressures for males not to admit to having psychological difficulties, especially eating disorders, because often what I've seen in my male Pakistani patients, that they associate disordered eating with being more feminine, and they really worry about this judgment. So therefore they will not come forward for treatment or will not admit that they've got some sort of problem due to the fear of negative judgment. I'm just wondering if the points that I've raised so far, is this something you can relate to? Is this something that you have all come across, or are these some of the difficulties you have also faced in your practice or in your institutions? Especially around the males. I'm just wondering if anybody has had similar experiences. It's just complete silence. Shall I take the silence as a yes or a no? Sorry.
No, like,
Right.
I also see clients, but, I haven't come across like, obesity.
Oh, sorry, Shahida, you just got cut off there.
I haven't experienced it.
Yeah. Okay, fantastic. Thank you. And I can see, I have not encountered any male patient yet. I'm a student, but around me, men binge eating. Yes, absolutely. Men, there's underreporting. So often you will see less males or very, very few males. And also binge eating seems more prevalent in males rather than females. So let's look at the data. Let's look at the prevalence, and this will give some understanding in terms of what is happening currently. So I'm just trying to use some statistics that I've come across more recently. So as we can see, as mentioned earlier, those who actually meet diagnostic criteria for anorexia or bulimia, it's quite small in comparison to the overall disordered eating presentation. So those who meet the absolute DSM or ICD diagnostic criteria, it's small. in percentage. However, all current treatments, hospitals, psychiatric units focus on only anorexia and bulimia. There's less focus on disordered eating, the atypical eating, so to speak. So this is why it's really important to think about atypical eating, disordered eating, and how to treat disordered eating as well. And of course, as mentioned earlier, there's significant comorbidity with eating disorders as well. So often it's associated with depression, anxiety-based disorders, OCD, social anxiety, PTSD, and panic disorder as well. And it's really interesting why there's such high levels of depression with disordered eating. So the research and the physiology behind this is that, of course, we all know, we all understand that we need serotonin to feel happy. And that's a particular hormone which will produce the kind of positive feelings in us and make us feel happy. However, if we are undernourished or we're not receiving the correct nutrition, what can happen in our brain? So if we're not eating or restricting our diet for long periods of time, tryptophan is not being produced, and tryptophan is a particular chemical that is required to produce serotonin. So even if you try to just focus on the depression without focusing on the nutrition or the food, you will not be successful in increasing the mood in that particular patient, because the intake of nutrition is not sufficient to produce tryptophan. It will not produce the serotonin, which will not allow or permit that patient to feel positive or to feel happy again. So this is why it's really important that we look at the link between nutrition, how the patient is eating, and how that will impact their mood. So of course, if they're not eating well, your mood will remain low. And if you think about it yourself, when there's been periods where we haven't been eating for long periods of time, we tend to become angry, irritable, and even it skews our judgment as well. Our judgment becomes much more negative. There's negative bias in terms of how we appraise many situations that we might be going through, and our judgment becomes more negative as well. So this is why one of the big reasons why there's a big association between eating disorders and depression, because the mood will remain low. It's only when you start addressing the nutrition and how the patient is eating, that's when the mood will start increasing naturally as well, because tryptophan will start being produced, which will help the production of serotonin. So there's a significant biological reason why patients with disordered eating and eating disorder present with a very, very low mood. And of course, we know low mood is often associated with anxiety, so it works hand in hand. And of course, we know with depression as well, if a patient is severely depressed, the motivation is going to be extremely low because they're feeling so down, depressed, and hopeless. And if the motivation is low, it will be very difficult to motivate the client to engage in a treatment as well. So it becomes a vicious cycle as well. And as therapists, it's really important we recognize these vicious cycles, give psychoeducation to the patient to break this vicious cycle and help them with their motivation and really help them focus on the motivation as well. So when thinking about the model, these are some of the considerations that were made when thinking about the model in terms of long waiting list, underreporting, how to see more patients in a less amount of time as well, how to equip therapists with the necessary skills to treat this patient group as well, and how to make sure it's done in an evidence-based way. One of the surprising things that everybody comes across when I deliver this training is that it's only 10 sessions, and people feel absolutely shocked. How can you treat quite severe disordered eating in 10 sessions? But I assure you it's highly effective. There's been lots of treatment, lots of research, lots of good evidence-based research to suggest it works. It's highly effective, and it's as effective, if not more effective than other treatments out there as well. So again, continuing with past difficulties, there's been extensive focus on underlying difficulties. So what tends to happen when a patient comes for therapy for disordered eating or those kind of low mood issues, and the disordered eating might be secondary, but the first issue might be trauma, the therapist has tended to just focus on the underlying problems. So they always focus on the underlying trauma. There might be trauma in the childhood, and the sessions tend to focus on the trauma or those family dynamic difficulties or any other difficulties which the patient might be presenting with. So there's been extensive over focus on the underlying difficulties rather than the here and now difficulties and the relationship with food. Often I hear this, and I hear this on social media as well, that when a person is suffering from an eating disorder or disordered eating, it's not just about the food. It's about the underlying psychological processes, such as the need for control or their way of coping with trauma. Of course, at one point in their life, that 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 would have been the issue. That it's all about trauma, it's all about control, it's all about managing their difficulties and emotional difficulties as well. However, by the time the patient comes to you, it's mostly about food and the behavior and the thoughts around the food. So this is why in this particular protocol, we're focusing on the cognitions around food and nutrition and breaking the unhelpful cognitions around that as well. Also, there's been extensive focus on therapeutic alliance. So this is an intervention-based protocol. There's less emphasis on you as a therapist building that therapeutic alliance. And the reason for that is, again, it's not focusing on historical problems, it's focusing on the here and now. And often I tell my patients that I'm not here as a friend for you, I'm here to help you get better. And my role is to help you get better, give you the correct treatment and advice, rather than simply being a place where you can talk and I can listen, because then I will not be able to help you adequately. I need to help you adequately. And part of that is making sure you are engaging in the interventions. I'm not here for you as a friend. I'm here for you as a professional to help guide you and break some of the unhelpful behaviors and cycles you're currently stuck in. Then also past difficulties have included far too many sessions. So often what can happen is that the therapist can lose focus and the patient can lose focus as well. And this is why this protocol is very specific. Session by session, I will be going through in terms of what to include in session 1 to 3, 3 to 7, 7 to 8, and then 9 to 10, because we need to be absolutely clear in our plan and share this plan with the patient as well, so they know what direction you are heading in, rather than leaving it open-ended. So it's really important that the focus is there, because in the past, it's lost focus. And also in the past, what we've noticed is that therapists and professionals will jump from one intervention from another intervention or a model. For example, they may use CBT, then they use DBT, then they use counseling, then they use psychotherapy, then they use psychoanalytic therapy. So there's a lot of drift. They're not staying focused. They're not sticking to one particular intervention to guide that patient through the treatment. There's been less focus on behavioral change as well. So of course, more focus on the patient opening up, the patient describing their difficulties, describing their histories, telling you about the problems they've been experiencing. But again, less focus on the actual change. There's been high levels of relapse in the past. There's been practitioner anxiety as well, holding back the treatment. So for example, the practitioner may feel extremely anxious to increase the nutritional intake in the patient. And of course, exclusion criteria is many services only accept severe eating disorders, such as severe anorexia, where they're severely underweight, or severe bulimia, where they are purging maybe 3 to 4 or 5 times a day. So this particular patient group where the disordered eating exists, they fall out of any exclusion criteria as well. So these are some of the past difficulties that we were mindful of. And this is why this particular intervention was delivered. And we need to make sure it works. We need to make sure there's low levels of relapse. And we need to make sure it's time limited. Because as mentioned, the more sessions you offer, the more you can lose focus as well. So these are the principles we agreed on, that it needs to be shorter than 20 sessions and agreed on 10. We need to make sure it's easy to deliver. Often there's this expectation that the more complex the case, the more experienced the therapist needs to be. And we need to get rid of this, because not every country or every area, whether that's in England or India or Pakistan or Iraq or Iran, has experts in their country. So we cannot wait for an expert to deliver this kind of treatment. So we need to make sure anybody can deliver this protocol and have adequate supervision as well. Had to be measured equally using the ED15. I will share this particular questionnaire. Very helpful questionnaire, helps the patient understand their difficulties better as well, and helps you as a therapist understand the patient's difficulties better as well in the questionnaire. Previously, all the questionnaires have focused on body image. So for example, there used to be questions on all the questionnaires, like for example, are you happy with your body image? And that's not useful whatsoever, because anybody will say no, nobody's happy with their body image. So the ED15 is a very effective questionnaire, which looks like eating patterns, behaviors, and attitudes towards your body image, your eating behaviors as well, rather than just thinking about how happy you are with your body image, because that kind of question will always get a negative response. So there's no point asking, are you happy with your body image? It needs to be accessible and acceptable to patient, and it had to be effective as well. So these are some of the grounding principles that we agreed on to deliver this protocol and to develop the protocol, making sure it's accessible, it's acceptable, effective, it's time limited, and it can also be used in other countries as well with limited resources, because that's really important. Many countries do not have excessive resources. So this is why all these thoughts and considerations were included when creating this model. So when thinking about, again, the principles of CBT-T and how this works, we need to address risk and therapy interfering behaviors. So of course, if there is risk of death present, we need to keep the patient alive. So if they're severely underweight, below their BMI, this particular protocol would not be appropriate for this client, because the focus needs to be on their physical health. So if you have a patient who's severely underweight, it might not be appropriate, and therefore physical intervention or medical intervention would be more appropriate. So we need to make that assessment in the first session. And also we need to address therapy interfering behaviors very early on. So this can be avoidant, not doing the diary, or not filling the diary in as honestly and as accurately as well. All these interfering behaviors need to be challenged very early on, and this requires some confidence and some assertiveness from you as a practitioner. Again, it's keeping that point in mind that I'm not here for you as a friend, I'm here for you as a professional, and therefore you need to be addressing any avoidance behavior, any collusion which may occur with the patient as well, and being very open and honest with them as well from the first session. Otherwise, the protocol will not work. The main point of the protocol, behavioral change. We need to ensure there's behavioral change from session 2. Again, this sounds really maybe surprising for many people, but we need to make sure there is behavioral change from day 1. The reason for this is research and evidence suggests where there is behavioral change from an early stage, the more effective the client will engage in therapy later on. Where there is no behavioral change in the early sessions, often there's no behavioral change later on in the sessions. And this is why you need to make sure that the client is making some significant changes early on, and that will determine the success of your therapy as well. So limit the number of sessions. It's 10 sessions. At session 4, we make a decision with the client that if it's okay to continue or not. If they're not engaging, we have to be honest that unfortunately, this protocol will not work with you. You have to be absolutely dedicated and committed to engage, and you need to make this absolutely clear from the first session. Otherwise, it will be extremely challenging for you to engage the client and make sure you are implementing this the interventions as well. So at this stage, I use many examples with my patients. So for example, I may say to them that if you go to a doctor, you have some sort of viral infection or some sort of difficulty like this, and the doctor gives you antibiotics, right? And on the antibiotics, it says take 1 3 times a day. And let's say, for example, I go back to the doctor the next week with the same symptoms, and the doctor will ask me, did you take your medication as prescribed? And if I tell them, no, I haven't been taking my medication, of course, the doctor will refuse to see me again because I am not following the regime of treatment. And this is why it's really important. We give examples like this to demonstrate the importance of making sure you are following your homework, following your diary, completing the intervention, completing the exercises. Otherwise, it will not be successful. So this is why we need to be absolutely clear that this is just not talking therapy. So often there's this misunderstanding and this assumption that people come to therapy just for talk, but we need to ensure we are telling them that change is required. We have to be active, and this is a principle of CBT, that the client is an active participant in treatment. They're not passive. So unlike other forms of talking therapies, such as psychoanalysis or counseling, where the client is quite passive, we need to make sure the client is as active and engaged in the treatment. And it's not just the therapist doing all the work. So often in supervision, my supervisors tell me, like, I'm really trying hard. I'm trying so much, trying to keep my client engaged. And often the power imbalance is completely skewed, because we need to make sure the patient is as engaged, as involved as in the treatment as well. The therapist is not doing all the work. So this is how we set the scene in session 1, making sure we are clear, honest, transparent, that if you do not engage, unfortunately, we cannot continue. It will require significant commitment and dedication from the patient as well. However, it's highly effective. So again, for my younger patients, often they will become quite anxious. They will become quite worried if they will be able to commit. And then again, I motivate them. I often tell them that you are only 16, 18. Let's say you do not follow the treatment plan and you do not recover. What are you going to do? So in 2 years' time, you're going to be in therapy again when you're 22. Then you might come back for therapy when you're 25. Then you might come back for treatment when you're 30. Do you want to continue living like this? Or do you want to do the treatment now whilst you are young? Wash your hands from treatment and then enjoy your life and enjoy your quality of life. Because I see many people in their 30s, 40s, and 50s who have been through many different sets of treatment, but they haven't fully engaged. And why would somebody want to be in mental health services all their life? Especially if it's a young person, I always encourage them, do the treatment properly now, because if you do the treatment properly now, you will be just able to enjoy yourself and not come back for therapy in the future as well. So the motivation is key. Setting the responsibility on the patient is key. All the responsibility does not fall on you as a therapist to make sure the patient gets better. So the 3 key principles of this treatment, and I will keep on coming back to these key principles of this particular treatment protocol, is breaking the cognitive link between eating and weight. So as mentioned, often there's obsessional fears that even a small amount of eating will lead to a disproportionate weight gain. So often I see many patients that they fear, even if I eat more than half than usual. So let's say I'm having half a portion of salad. If they feel if I have the full portion of salad overnight, I will gain 1 stone or 2 stones or 60 kilos in one night. So often there's this misinterpretation and misproportionate cognition and judgment of how much weight they will gain. And also the second fear is any weight gain will be uncontrollable and unstoppable. So often many patients I see, they absolutely fear that once I start gaining weight, I will not be able to stop gaining weight. So I might gain 1 stone in maybe 1 month, and I'll keep on gaining until I'm like 20, 30, 40 stone. So again, this is the anxiety and the irrational fear, which is feeding some of this behavior. So the first phase of therapy is breaking that cognitive link between the eating and weight, and the fear between eating and weight gain as well. And this goes back to the theory and understanding of anxiety and how anxiety works as well, because fear is generalized and safety is localized. So what I mean by that is, let's say, for example, when you're working with trauma, right? And you may have a person who has been attacked or assaulted in a street near to where they live. Their brain will generalize that fear. Now everywhere is dangerous for that patient. They may be in anywhere in a different country, different location. They will still fear being attacked, because that's your body's anxiety response to protect you and help you. So it will irrationally generalize that fear everywhere you go. So your brain is not that sophisticated to tell you and to make you understand that just because you were attacked in that particular area, that area is unsafe. You will feel unsafe everywhere. So I see many patients who suffer from trauma. They will tell me they got attacked in this particular area, but they're unable to leave the house or go anywhere else now because they find everything scary and fearful as well. And then safety is localized. So what I mean by that, they will only find some places safe. So for example, if I stay in my house, I will be safe. If I go anywhere else, I will be attacked again, and I will live in the state of fear. Similarly with food, and weight gain, this is how it works, that the fear is generalized. If I eat any food whatsoever, I will gain masses of weight, and therefore the safety is localized. So they only pick certain foods, and you will see this in many patients, that they will only pick certain foods because they feel safe with this food. So salad, lettuce, carrots, things like this, they will only pick certain foods. Or I had one patient who would only eat a particular biscuit because they felt with that particular biscuit, they will not gain weight. So the first phase of treatment is breaking this unhelpful link between how they think they will eat and how much weight they will gain as well. And it's really clever how we do this, and it's really helpful. And inshallah, we'll do some role play so we can practice this as well. Then the second phase of the treatment is emotional triggers and the underlying belief structures. So often we see in many patients that they are emotional eaters. So often because they're feeling sad, or because they've remembered a certain difficult memory, or they may have some negative core beliefs about themselves. I'm a failure, I'm an inadequate. So when experiencing those thoughts, feelings, and emotions, that will trigger a particular binge eating episode, or they will stop eating altogether. So the second phase of treatment is addressing the emotional triggers, and this is very common in emotional eaters, or we are looking at the underlying belief structures or the core beliefs which trigger these kind of eating behaviors. And then the third part of treatment is the over-evaluation of eating, weight, and shape. So this is looking at check-in behaviors. So some clients may be weighing themselves excessively 3 times a day or maybe 4 times a day, just because they're worried their weight will gain. Those people who are checking their body excessively using some sort of tape measure, or the opposite, they will not weigh themselves because they're absolutely fearful that if I weigh myself, somehow I will find out that I am gaining weight as well. Or comparison. So often I see many clients who are comparing themselves to others, or there's a fear of judgment from others as well. Other people will think I'm fat. Other people will think I'm eating too much. So in the final stages of therapy, we look at the over-evaluation of eating, weight gain, and body shape as well. It's really important to look at the body shape. So these are the 3 particular phases we follow, and this then effectively leads to this particular structure. Sorry, that graphic is not clear, but I've included a more clear graphic here. This is how the sessions are structured, and the 10 sessions are structured. So first, of course, engagement, assessing, and looking at the maintaining factors. Measurement of outcomes, so the ED15 questionnaire, discussion with patient, response to no change. So of course, if there's no change and the patient's engaging, we can't continue with the therapy. There's no point in continuing. Monitoring risk and safety, that happens throughout. Maintaining alliance and motivation, again, you maintain that throughout the 10 sessions. You are always maintaining your therapeutic alliance and always maintaining the motivation as well. Psychoeducation and cognitive structuring, that's happening throughout the 10 sessions. Changing eating and exposure, that's happening in the first part. And then changing eating behaviors, the behavioral experiments, reducing binging and purging, the exposure work, body image work, and reducing emotional triggers to bulimic behaviors. And then finally, we're looking at the relapse prevention plan. So this is the overall structure before I go into the actual session by session details, but I wanted to provide you with an overall structure of the sessions, how the overall treatment works, and how to make it effective, because we need to follow the underlying principles for all this to be highly effective. So of course, the evidence is there. I'm just conscious of time, so I'll go through this very quickly, that this works just as good to those therapeutic interventions, which are 20, 30, 40 sessions. In fact, it works better than them. There's no evidence or difference that brief therapy will be less effective than longer term CBT. Also, the outcomes demonstrated that when this treatment is successful, that the anxiety, depression, and quality of life significantly becomes improved as well. And personality disorder cognitions changes. So how they perceive themselves completely changes as well. And there's similar outcomes in adolescents. So this treatment is not just for adults, it's for younger people as well. So the research has been conducted. There's been various studies on this, randomized controlled trials as well. So there's significant research and evidence to suggest this is effective, it works well, and that you can do this. You do not need extra specialist training or qualifications to deliver this. You can deliver this and it can be as effective as long as you are following the protocol specifically and exactly as it is detailed. So just really quickly looking at these changes in behaviors and attitudes, so we can significantly see at the start of therapy by session 4 and session 10, the objective binges have reduced, vomiting has reduced, and use of laxatives has reduced as well. And the EDEQ, which is another similar questionnaire to the ED15, there's significant improvements as the sessions have progressed. So again, significant evidence to say it works, it's effective, and it can be delivered. So nearly all non-underweight patients are suitable to try it. Nearly all patients agree to undertake it with a decent working alliance. It can be delivered by well-supervised trainees and assistants, and substantially cheaper as well. It works at about the same level as existing 20 sessions of CBT-ED. So those who have been trained in ED, it's a very extensive form of CBT. Again, it works just as well, and it does demonstrate early symptom reduction, also reduces comorbid anxiety and depression. So of course, fingers crossed, by the end of today, you will have some idea of how to deliver this, and then inshallah, you can practice this on your patients, deliver it on your patients. And of course, I am here in the background to support you with any supervision that you may have or any difficulties that you may have as well. So I'm realizing I'm speaking a bit too much. So just before I move on to the next part, any questions, thoughts, or reflections so far at all? Okay, that's fine. We will have a break in the middle at 7:30. Sorry, I'm looking at UK time. 7:30. I think Pakistan time, it'll be 7:30. So in 30 minutes, we'll have a break as well, because I can understand it's a 3-hour session, so it can become quite intense. So what I suggest to all my trainees and all the qualified staff I supervise as well is to keep this protocol checklist with you in all the sessions. It's really important. And why we use it? Because we're human, after all. Often we can forget what to include in a session, what to not include in a session. So it's really important we have this checklist to follow. If we follow the protocol, we get greater outcomes, and it restricts us from drifting onto different topic areas or different areas of focus. It is really effective when following this checklist. And of course, we just need to be completely honest with the patient as well, and transparent with the patient as well. Yes, of course, we will go for a break, inshallah, then 7:15. That's perfectly fine. And of course, I will email out the checklist and all the other questionnaires as well. And like I mentioned, I will give my contact details. So yes, you can have that. Also, what I do with my patients as well, I share this checklist with them. And again, this helps the patient understand what I will be doing in every session, because it's absolutely important. I'm honest, I'm transparent. I guess just like yourself, if you're going to some sort of professional or you have some sort of medical problem, you want to know what they are going to do with you. You want to know how your expectations will be managed. You need to know what to expect. So this reduces some of the anxiety as well. So I share this checklist with them. I tell them that this is what we will be covering. This is what we will be doing session by session. And often this empowers the patient then, because the patient is more motivated to engage. They're excited about what's coming next. And also it's managing expectations that this is not a trauma focused CBT. It's not looking at purely just a depression. It's looking at those behaviors, those cognitions around eating, and the appraisal of your body image and weight gain. So this is really helpful that you have this for every single session, because this will help you keep on track and not let you drift as well. So of course, as I mentioned, and this is, I guess this goes for any form of CBT as well. The patient is the therapist, you are the coach, so you are guiding the patient, and it's the patient doing the hard work as well. And of course, how should a coach respond if their advice is being ignored? We need to address this, that if you are not following the protocol, if you're not following the advice and interventions, I can't help you. So the patient really needs to engage as well. Therapy is not presented in sessions. So I never say, in the first session, of course, I'll say, look, we've got 10 sessions, but I really stress therapy being presented as 168 hours in a week, because what you do in just 1 hour in the therapy room is very limited. It's really important to stress that most of the therapy happens outside the therapeutic room, where the patient is practicing these techniques, engaging in these techniques and implementing these techniques. So it's really, really stressing that this is a large commitment, a large amount of work will be happening outside the therapy room as well. And it's homework driven. There's a large amount of homework. So this is why I always tell them therapy is 168 hours a week, where you need to be constantly thinking about therapy, constantly thinking about your eating behaviors, how you are eating, how you're engaging in the therapy as well. And it's not just something you come here and talk to me about for 1 hour, leave, and then forget all about it. It's really important that you continue to think about this and engage in this outside as well. And there's 3 states of therapy. There's those who are actively in therapy, those who are just attending therapy, and those who are doing therapy as well. And you can feed this back to your patient as well. How you perceive the patient is attending in therapy is really important. And always set 5 minutes on the agenda to deal with non-compliance. So you may have a patient who might say, I did not do the diary. Address this very, very early on, so you are managing your expectations and expectations of the patient, rather than allowing that to linger and not setting the rules from day one, because otherwise the non-compliance will increase as therapy sessions increase as well. So it's really important we set the scene from day one. Do not offer a full course of therapy, because we need to look at the engagement. Again, just like I mentioned, when we go to a doctor for some form of treatment like antibiotics, or even if we look at, I've been working in like a bariatric service as well, where there's overweight patients and they require the gastric band operation. Before that particular surgery and before that particular operation, they need to demonstrate they are committed to changing their diet and their behavior. And of course, if they're not able to demonstrate that, the surgeons will not perform the surgery, because they need that dedication from the patient. So again, really making sure that if you are not engaging by session 4, cannot continue with you, we need to review this progress in a very honest and firm way from session 1. Because if we are not honest and firm in session 1, unfortunately, that behavior will continue. And then again, thinking about behavioral change is very important. Immediately start motivating the client to change that behavior. And be honest, if there's no behavioral changes by session 2, unfortunately, recovery is highly unlikely as well. Use positive reinforcement and always ask about previous therapies. So maybe often I have many patients who will tell me they had good CBT in their past, and then we talk about this. How good was it? Because you're back again, so it couldn't have been that good. Or they may say to you, as a form of a defense mechanism, that my past therapist did not encourage me to make these changes, or was not focused on these changes. And again, really state that effective therapy involves behavioral change. Without the behavioral change, the therapy will not be effective. So this is why it's really important to get their past experiences and see what's happened in the past. So often at this point, the therapists are feeling really anxious, because there's so much focus on engagement, behavioral change from session 1. So the therapist is really anxious as well. So it's really, again, thinking about your own anxieties, how to manage your anxieties. Do not let your own safety behaviors get in the way of that patient recovering. So you may become passive, you may become quite forgiving as well, in terms of it's okay, we'll continue, we'll try harder, we'll continue, we'll try harder, and that trying harder can go on to session 6, 7, 8. It's not going to work. You need to really stick your ground, and you need to deal with your own anxieties as well. We need to tolerate our own uncertainty as well. So the patient may tell you that I'm really worried if I gain too much weight, I will not be able to continue with therapy. And that's fine. That's okay. That's a temporary judgment they're making there. We need to sit with that as clinicians, and we need to stay engaged with the patient as well. And it does not matter if the patient hates us at the end of the day. Our aim is to get the patient well. So even if they dislike us, it's okay. Like I mentioned, we're not their friend. We're there as a professional therapist, a professional person working in mental health. Our focus is to get that patient well and functioning again. And therefore, we need to remain assertive and firm with the person and the patient as well. So the aim is to achieve recovery. Be clear as to what constitutes as recovery. So it's changing the way we think about eating and weight, looking at the emotional triggers, and looking at the over-evaluation of eating, weight, and shape. We need to normalize eating attitudes, stop bulimic behaviors, normalize weight, and body image acceptance. These are the focus of what recovery looks like in this particular model. And this is what we will be focusing about. So again, identify your target, be clear about what we are aiming for, looking at the broken cognition, making sure we express to the patient from day one, we expect completed honest diaries, even maybe eating in the session with you, that will happen. Overvalued ideas about eating, weight, and shape, we will be addressing that as well. And everything we do in CBT should have all this in mind when focusing on this protocol. And as mentioned, it's firm empathy. The alliance improves following behavioral changes, because when they see this is actually effective and this is working, the alliance will increase. To get the change, we need to combine firmness with empathy. And this is why explain your stance to the patient. And this needs to be focused in supervision as well. And if you are supervising, be honest with the supervisors about how they are doing. Beware of the dangers of being too nice, because essentially we need to be firm, assertive, and help that patient. So this is why it's slightly different to traditional psychotherapy and CBT. It's really being firm, it's really being focused, and it's really explaining to the patient that behavioral change is a must. If that does not happen, we cannot continue. Focus on one thing at a time. The patient may bring past trauma, other difficulties that have been experienced in the week. So I have many patients who may say, I've had this problem, that problem in the week. So we need to stay focused, and yet use the protocol flexibly according to the needs of the patient. So it's 1:15. Inshallah, we'll go for namaz break, and then we'll start again. It's 10 minutes, would that be okay? Please, if somebody could put in the chat, 10 or 15 minutes, how much would you like? Great, inshallah, we'll have 15-minute break, and then inshallah, we'll pick up in the 15 minutes after the break then. Okay, I'll see you all in a bit. Assalamu alaikum and welcome back, everybody. Please do let me know in the chat if it's okay to start again.
I'm present, and I guess the rest of the people will be here till 7:30.
Fantastic. No problem. Fantastic. Thank you, Mohammed. I'll make a start. So just before the break, we set the scene in terms of expectations, how to implement the protocol as well. And then now finally thinking about the sessions and how the sessions are structured. So I will go into a lot of detail about how to conduct each session. Inshallah, if I have time, I will try my best if we can fit in role plays here and there as well. It'd be really, it'll just make it so much more meaningful and helpful. And then, yes, I'll take any questions at the end as well, but please do send questions in the chat as well. There was a question on depression, which I will come to as well slightly later on because it may get answered. So think about the first session and setting the scene. Like I mentioned, it's really, really important. Use the protocol list. The themes for the very first session is, of course, engaging the patient, providing them all the psychoeducation, establishing the rules. Homework's absolutely important. 2 rules as well, which will happen in every single session. Completion of food diary and making sure you are being weighed in every single session. So the patient has to agree to being weighed. There will be anxiety around this. There will be resistance around this as well. But it's really important demonstrating why we need to weigh the patient. And I'll shortly come on to that as well. Also explaining changes need to be implemented very early on. And I will provide all the information in terms of the questionnaires, the checklist, the diaries as well for you. So you have a complete pack as well. So when looking at the 2 key tools for the first session is the diaries and the weighing. Without the diaries and the weighing, it will not be effective and it will not work. And the reason for this is, well, it needs to be accurate. And we also thinking about the aims of working with eating disorders and disordered eating is unlocking that link between eating and weighing, because often there's that fear that even if I eat a small amount of food, it will lead to disproportionate weight gain. And also the second fear is that if I do start eating again, or I do start eating more again, there will be uncontrollable and unstoppable weight gain. So yes, Shahida, sorry, the presenting problem is often eating disorder, disordered eating. There's comorbidity of trauma and depression, but we look at the comorbidity later. The reason for this is, the reason why we focus on the nutrition first and we focus on the link between the food and the cognitions first is because that will help you establish emotional stability, because you can do all the DBT, you can do all the stabilization skills and interventions. Unless the patient does not have sufficient nutrition, their mood will not stabilize. So like I mentioned earlier, if you're not eating, you yourself, you will notice your mood dip, you having rapid changes in your mood and becoming quite irritable and angry. The reason for that is because your body is craving nutrition and food, and without that nutrition and food, your mood will not stabilize. So this is really important, why we start on the nutrition, not looking at the depression, anxiety, or the trauma. That comes later on, because this is really important. If the nutrition is there, the mood stabilizes. I'll just jump ahead. This is just a small graph to illustrate this. So for example, if a patient, and this is looking at the energy, but we can also relate this to the food as well. If a patient is starving themselves, their mood will dip and their energy levels will dip as well, because they're starving themselves, their body is not getting enough energy, not enough nutrition. And then by evening time, more than likely they will binge in the evening time. The reason for that is, for example, if you use this example with a patient, let's say you go swimming and you start to drown and you keep your head below water. As soon as you come up and out of that water, your body is gasping for air. So what will happen if you've had your head in water, as soon as it comes up, it's like, it's trying to take all that air and oxygen in because you're trying to breathe. Similar with food. So if you've been starving yourself since the morning, you've had no breakfast, you've had no lunch, you may have been exercising excessively as well. As soon as you eat anything, your body will go into that uncontrollable state and try to eat everything. So you'll end up binging. Very similar to how our body works. Like I mentioned, if you are drowning and you come up out of the water and you're gasping for food, similarly, for air, you want to take in as much air as possible. And this is what's happening when you're binging and your mood is extremely low as well. And of course, if you're binging throughout the day, your mood will be up, down, up, down, up, down, because you're binging, taking in food, then you're purging, your mood will drop, then you will binge and drop, binge and drop. And this is how your mood fluctuates as well. So this is why we do not focus on the anxiety, trauma, or depression first. We focus on the nutrition, because if you have a balanced diet, that will be reflected in your mood as well. Similarly as well, what can happen with binging after the binge? So many people will say, I had the binge in the evening, then I felt sick. I felt disgusted with myself. I felt like I wanted to kill myself. I felt fat. I felt awful, and all the negative cognitions will kick in. And this is why we're addressing the binging behaviors and the restrictive behaviors very early on in therapy. If we do not address this, you'll keep on coming up with the same barrier over and over again later on. And often, because of the negative feelings, the binge has triggered about feeling disgusted, feeling unworthy, feeling inadequate. They will purge. When they purge and be sick and vomit, your electrolytes change in your body. And because your electrolytes change in your body, you will feel extremely tired, down, depressed, hopeless, and fatigued. So all these biological and physiological changes are happening just because of the imbalance of how you are eating and how you are binging and purging. And this is why it's really important we start with the nutrition first. If we do not start with the nutrition, you will not be able to treat the depression, anxiety, or the trauma as well. So these days as well, another issue is on social media, we have so much access to the internet now, which we never had in the past. There's so many weird and wonderful diet regimes, nutritional advice from many so-called, TikTok experts as well. It's really hard to get some sort of accurate information. So this is the food chart I use. It's called the Real Food Guide. And this is available. I will send the link for this as well. And if you notice in this food guide, it's not restricting how much and when, because we are introducing flexibility. We're not introducing more rigidity. And this is why it's really important just to use the food guide as a guide, not for being completely rigid in terms of this is how much you have to eat and when you eat, because we are introducing the flexibility to the patient, not introducing more rules around their eating. So the Real Food Guide, that's available online. I will send the link, and it basically stands for recovery from eating disorders for life. So in this particular guide, it looks like the different types of food. It also looks like chocolates, pizzas, and cake, how that can be eaten within certain amounts as well, but it's not overly rigid. So you're looking at the 3 meals, you're looking at the breakfast, lunchtime, and evening time, snacks as well, but keeping some sort of chart. Sorry, if the chart is not visible, I'll send that in the email so it's visible. So of course, in the very early stages, you will be faced with so much anxiety, so much resistance from the patient as well, and fears. They will be absolute in a state of fear that if I start eating and if I increase my diet intake, of course, my weight will increase rapidly. They'll have a disproportionate view on how much their weight will gain. It'll absolutely be completely irrational. And also there will be a worry that once my weight starts increasing, it will not stop. It will not balance out. So these are the 2 worries and resistance factors that you will face. And this is how we overcome this issue and how we overcome this problem in terms of looking at how to get the client to eat, first of all, how to increase and how to make sure they're eating throughout the day. Because if they are not eating throughout the day, they will more than likely binge in the evening and nighttime, because again, the body is absolutely starved and it's feeling extremely, extremely hungry. And this is why the binging occurs. So if the patient is eating throughout the day, they're unlikely then to binge in the evening. So to do this, I will do a bit of a weight game. Sorry, I'll do a bit of a role play for this to demonstrate how we introduce nutrition, how we introduce increased nutrition for the client and increase the amount they are eating as well. And we use this particular chart to do this, and I will send an empty chart so you can use this with the patient. So for this, inshallah, I need a participant, a volunteer, a really kind volunteer who can do this with me. And then I will set the scene for you. And then inshallah, we can do the role play and we can look at how to do this. So please, if anybody can volunteer, I'm actually going to be a bit picky here because I'm going to ask for a male volunteer. And the only reason for that is often we have less male therapists globally around the world. And obviously there's less male patients as well. So it would be really good, inshallah, if I could have a male who would be willing to do the role play with me. I'm not sure if there are many males in the group anyway. And this always happens, no male, and they never volunteer. That's fine, no problem, don't worry. I think we have a female therapist who's willing.
Yes, I'm willing to do so. My name is Anora.
Anora, thank you so much, Anora. I suspected that was an assumption that will happen, but never mind.
I thought that there was no male, so I can volunteer for that.
That's fine, no problem at all. So what we're going to do is a role play. It's second session. Okay. And in this particular session, I am going to try to introduce more food in your diet, okay?
Okay.
And we're going to think about some of the fears, some of the predictions about you eating more. So in terms of the role play, if you just imagine you're a female patient who has been suffering from restrictive disordered eating, so really restricting your diet, maybe just having one small meal per day.
Yeah.
Your fear is that you will gain excessive amount of weight if you do start eating. Is that okay with you?
Yeah, perfectly fine.
Brilliant. If you could just tell me, Anora, sorry, I'm really bad with technology. This is just my old age showing now. Can you see the Word document or can you see the presentation on the screen?
I can see the presentation.
The presentation, 1 second. Yeah. I will just share the Word document because this will make more sense.
Okay.
Can you see the Microsoft Word document now?
No, I still see the, yes, it's a Microsoft. There's a graph on it.
Fantastic. Brilliant. Excellent. 1 second. I'll just edit this. So, okay, we'll do the role play, and what we'll do after the role play, we'll have some question answers. If anyone's got any questions or answers, we can address them. And also some feedback will be really helpful, as in what could we have done differently, what could have been better or not so better, and just some reflections around the role play. So we'll go into, I'll be therapist, you be patient. So we'll go into that mode. So Anora, thank you very much for coming back. This is our second session today. We have 50 minutes together, and in this session we agreed to look at maybe introducing some more food in your diet, some variation in your diet, and maybe thinking about how you can increase the amount of meals you have per day. Is that okay with you as the agenda?
Yeah, that's fine. For now it's fine. Let's see how it goes.
That's fine. I can sense you're feeling quite anxious. Would that be fair to say?
Yeah, I'm just thinking that it's quite challenging for me. Well, let's see how it goes.
Thank you. Yes, no, that's completely normal. That's completely fine. At this stage, it will feel quite anxiety provoking. It will feel quite challenging, but I am here to support you and help you through this process. So Anora, you've completed a food diary for me, and I can see in your food diary that you're currently only having one small meal per day. Is that correct?
Yes.
Okay, one meal per day. And could you just tell me, in that one meal you have in the day, what's in that meal?
So I'm taking one orange juice, and sometime I'm having yogurt. That's it.
Okay, so one orange juice, and you said only sometimes you're having one yogurt.
Sometime. Yeah, sometime.
And after you've had that orange juice, how are you feeling?
So when I have the orange juice, so having the orange juice is good.
Mhm.
But straight after that, I feel like that maybe it's way more calories.
Way more
And
calories.
I can have, and I can put on weight. And
Mhm.
then I don't want to see myself in the mirror
Yes.
because it seems so like I'm chubby, I'm fat, and I can't wear the dress that I want to wear. And
Yes.
people will judge me.
Mhm.
So it kind of then stops me, like I said, sometimes. So then I don't feel like eating.
Yeah. Yeah. Thank you so much for sharing that with me, Anora. So I guess my understanding is that you don't feel like having more than that because you worry, like you said, you'll become quite chubby. You won't be able to wear the clothes. And of course, people will judge you. Have I understood that correctly? Sorry.
Yeah. And I don't like seeing myself in the mirror because I don't like seeing the physical body, how I appear then. I feel like as if I feel like I'm already quite fat and chubby. And if I eat, like I start eating,
Yes.
although sometimes I want to eat, but if I start eating, then it will be like I will put on more weight and fat.
Yes.
And then I'll hate myself, and that make my mood really low.
Okay. Okay.
Yeah.
So you hate seeing yourself in the mirror, like you're saying, it will make your mood really low. Just out of interest, Anora, how often do you see yourself in the mirror at the moment?
So I only see myself in the mirror when I'm not eating like 2, 3, 4 days, and then I feel like yes, I'm quite slim. Otherwise, I don't want to look at the mirror.
Okay.
I covered all the mirror in my room with the sheet. So because I don't want to.
So I understand that you avoid looking in the mirror because you just do not feel happy about yourself. So you want to avoid looking at that, right?
Yeah.
Okay, I understand. So thank you for sharing that with me, first of all. That sounds difficult. This sounds like some really difficult thoughts that you have to go through and some really difficult experience there, but thank you for sharing this. So just coming back on track, like you mentioned, you're only having the one meal per day, which consists of orange juice and then a bit of yogurt, like you said, only sometimes. We talked in the last session how important it is for our mood, of course, and the way we feel that we start introducing some more nutrition, because without the nutrition, unfortunately, your mood will still remain low. And it's really important that we start introducing that nutrition, not just for your physical health, but for your mental health as well. So we need to start focusing on that and setting a bit of a plan in these early sessions, because that will help us progress through therapy and hopefully help you recover from the difficulties you are having. So what I wanted to discuss with you, you're having one session, one meal with the juice and the yogurt. But like you've mentioned, you feel tired, you feel down, you feel disgusted in yourself as well. And we need to start looking at increasing this intake in food, which will help you. I know this sounds unbelievable at the moment, but it may help you with your mood and how you feel about yourself later on. And I can completely understand this feels quite unhelpful to you at the moment. However,
it seems like as if I like the idea that you're introducing, as if I start eating like normal people do.
Yes.
I think it will be very gross for me, and I will just lose the control that I have on my eating, and maybe then like it feels so scary at the moment.
So I guess what I'm hearing there is that you've got that fear. A, it's too scary, and B, you will lose control. Is that correct?
Yes.
Okay. So shall we test that? Shall we see if you do lose control? And shall we test how scary it is?
How are we going to test that? That's so like,
Look,
how?
How? Okay, we can think about that in terms of how we'll test that in terms of the fear, of course, it being uncontrollable and obviously being far too scary for you as well. So
Yeah.
what I was thinking, let's look at the food chart that I showed you. And
Yeah.
obviously let's look at the recommendations. And of course, as you know, Nora, that the recommendations are 3 meals per day.
Yes.
Thinking about your breakfast, first of all, what do you think would be a manageable amount for you to start having in your breakfast?
I think I would like to go still with orange juice or any other kind of fresh juice.
Okay, just juice. How can we introduce some actual food in your breakfast?
So maybe I would like to add a banana or maybe some cereal.
Some cereal? Okay.
Yeah.
Okay. So we weighed yourself, we did your weight, and you're currently 49 kgs, right? Kilos,
Yeah.
sorry, 49 kilos
Yeah.
at the moment. So
Yeah.
you, with the introduction of the breakfast, like for example, orange juice plus banana plus cereal,
Yeah.
what's your prediction? How much weight do you think you will put on by the next session next week?
I think I will be putting on maybe 55 kg.
55 kg. Okay, so I'll write this down. So your current weight is 49, and you
Yeah.
feel that after you've introduced the banana and the cereal and the yes, with the orange juice, you'll increase your weight by 55 kg by next week,
Yeah.
right? Is that
Yeah.
right?
Yeah.
Okay, great. So that's with breakfast. What about lunchtime?
Yeah. Oh, gee, I cannot think about having a lunch after having such a heavy breakfast.
Okay. What's the fear? What do you think might happen?
And like I told you, I think like if start eating like this, it will be my weight will be way more than that, and it will kickstart. I will feel so bad about myself. I will be unable to go out for my university and
Yeah.
doing the thing.
So you'll feel extremely bad and your weight will continue to increase. So let's say, hypothetically, you start introducing lunch. What's your prediction? How much will the weight go on plus breakfast plus lunch by next week? What do you think?
I think it will be around. I think I'll pick maybe 58.
58? Okay.
Yeah,
Okay.
58. Yeah.
By 58.
If I
Okay.
start, yeah, lunch and with breakfast and lunch put together.
Okay. So with lunch, with breakfast, you predict that your weight will be 58. But like I mentioned,
Yeah.
it's really important we commit to this and stick to this, because I guess we need to figure out if it's true or not. If you start eating, you lose control or your weight will grow so rapidly. We need to check if this is true or not, because without this, we won't be able to move forward. So let's set this as a task for you, Anora. Any barriers that may come in the way of you completing this task?
I think I think if I think that, oh my God, if I'm worrying too much, then I think maybe I skip the meal.
Okay. So let's think about that. Like I mentioned, it's really important we don't skip, because when we skip, remember I told you you're more likely to binge then if you're skipping.
So
if you're going to skip, you're going to binge in the evening.
how am I going to tackle this situation? Like,
Okay.
I will try my best.
Yeah.
Because like you said, it's an experiment.
Yes.
So we need to see how it goes.
Okay.
And for how long, for how many days I have to like really stick to this, because.
Okay, shall we just do 1 week to start with?
Okay, 1 week.
Yeah.
And
So, because I guess you can come back next week, we can do the weighing and we can see how much the weight has changed.
Okay, I can try. I'm not committing 100%, but I can try my best, because sometimes the anxiety is way more that I just can't control it.
Okay, so that's really interesting, because the anxiety is there when you're not eating, and the anxiety is there when you're eating as well. What does that tell you about the anxiety?
Well, it's strange. I never looked at like this.
Yes.
So when I'm not eating, the anxiety is more like kind of, the anxiety is still there because I'm feeling bad and
Yes.
I'm feeling low.
Yes.
And then when I'm eating, the anxiety is more like, oh my God, I'm eating. And then
Yeah.
what's gonna happen? And then like, yes, I never thought like this before.
So the anxiety is going to be there even if you're eating or not eating. So I guess
Yes.
what I'm saying is I'm not really telling you to do anything different. Keep the
Yeah.
anxiety like you always have so far. All I'm saying is let's just try eating a bit more, and then we can weigh ourselves and see what happens.
Okay.
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 So you're committing to banana, cereal, lunch as well, plus your
Yeah.
existing orange juice. How will you keep track of this? How will you ensure you're doing this daily? Are you writing this down?
So yes, I can write this. I have an app in my phone,
Fantastic.
and then I can record in there, or I can record in my diary.
Great. So what we can do, come back next week. You need to be, like I mentioned, absolutely honest that you have been eating this. Maybe if you take some pictures to show your meal, that will be really helpful, because then we can look at portion size as well. And then of
Okay.
course we can do the weighing. Of course, I agree with you. If it's increasing far too much, maybe I'm wrong. Maybe this is not helpful and I need to think of something else. Or we can of course look at the other result. It might not have increased, but it sounds like you're probably thinking it's going to increase too much. Is that right?
Yeah. Yeah.
Yeah.
And then I reckon that I will be measuring my weight every day when I'm having the breakfast and the lunch. So obviously that will give me a fair idea, the objective idea that how much I'm putting on the weight.
I'm just thinking about that. Like you said, you'll be weighing yourself every week. How helpful do you think that is?
Not every week, every day, like for this whole experiment, when I'm having the breakfast in the morning and then the lunch, I feel like as if I am already putting on the weight. So I will be
You're
checking
already.
on like,
Yeah.
yes.
Okay.
Yeah.
Okay. So let's just focus on the lunch and breakfast for now. Let's come back next
Okay.
week and then see how much weight you've actually put on, and then we can take it
Okay.
from there, Nora.
Okay. Okay.
Brilliant. Thank you very much.
You're welcome.
So that was brilliant. Thank you so much for that, Nora. So in terms of that process, what we were looking at over there is the prediction and the actual. So what actually happens, the patient will continue to predict much more higher weight gain in terms of the actual weight gain. So they will assume, just because I've introduced some more nutrition, some more food, and this is why it's really important to do the graph with the patient, because when you are doing the graph with the patient, they will start to realize what I am predicting compared to my actual weight gain, it's completely different. And this will start increasing their confidence that you can start eating more without significantly putting on significant amount of weight, because your body is highly resistant. It has an excellent metabolism. So even, for example, when we eat more, if there's some sort of celebration like Eid or anything like that, that doesn't necessarily mean we will put on the weight overnight or our clothes will never fit again. So that's the irrational fear and that's the anxiety driving that. So when Anora comes back next week and we're doing the weighing, 99% what will happen is that the prediction is much higher than the actual weight. And this is why it's really important you do the weighing in every single session. So I will just do share screen again to demonstrate this. This is a typical graph that I have with my patients. So often what will happen that their prediction is much higher than their actual weight gain. Of course, there's some weight gain in the beginning because the body has been starved from food for such a long amount of time. So it will hold on to every part of food, but then it will balance out. And also this demonstrates that it's not uncontrollable. The anxiety will make the mind think that it's completely uncontrollable and the weight gain will continue, but it doesn't. It often relaxes and it plateaus, so they often balances. So just before I move on to the next part, any thoughts, questions, or reflections on the role play first of all? Sorry.
One question, please, sir.
Yes, of course.
Sir, in your opinion, what is the best strategy to make a patient compliance improved?
Mhm.
Like if he or she is reluctant to be waited, not completing the diary, what will be your preference as a therapist? What will you suggest? What to do?
So often at that point, I do the cost benefit analysis. So I will often create a table with the patient looking at the costs that, okay, if I do not do the diary, if I do not engage, what's the cost? So I'll continue to feel bad. I will continue to feel rubbish about myself. All my symptoms will continue. Unfortunately, with eating disorders and disordered eating, what can happen over time, it can start affecting your organs as well. So there's a physical cost as well. And then we'll look at the benefits that actually, if I do engage in this treatment, if I do start making some changes, of course, then these are the benefits: quality of life. I can start looking at my future. I can start doing things that I stopped doing. I can start eating with my friends again. So cost benefit analysis is often really, really useful. Motivational interviewing with the patient as well. Often putting the patient in terms of patient and friend shoes. So what I mean by that is often I will say to the patient, if your friend was in the same situation, if your brother or sister or parent was in the same situation, how would you be advising them? So these are some of the techniques to motivate the patient. But cost benefit analysis is often I found really helpful to help the patient reflect as well what cost this is coming at. I don't know if that helps, Dr. Kehkashan, sorry.
Thank you, sir. Thank you.
Most welcome. So first part, exposure and nutrition, push this as much as you can, because the weight gain, the actual weight gain is far less than what the patient is predicting. And this is where you start breaking the link in terms of the fears and the anxieties. And often another secondary consequences of this, because they're eating, they're feeling fuller, they're getting nutrition, the mood starts improving as well as the weeks progress. So this is really important for your first stages to make sure that you start introducing this. The second stage, I won't go into too much detail because I'm just conscious of time, is looking at the binging and explaining why the binging occurs. So as I mentioned earlier, of course, if you starve yourself all day until the evening time, of course, then you're going to binge. So it's really important that you have bits of food to eat. Similar to yourself, you may have been hungry all day, you haven't had a chance to eat because you've been busy at work. Often you'll end up eating more than usual in the evening because your body is absolutely craving the food. So we need to maximize the tolerance, maximize the results in the first session, and really ask them, okay, eat cakes, eat biscuits, predict how much weight you will put on. They will often over predict the amount of weight and show that in a graph form. It's really important you show that with visual aids to really demonstrate what's really, really happening. So once we have conquered that, and make sure this continues in the background, this needs to continue. Their predicted weight and actual weight, that continues in every single session. We then move on to phase 2, which is behavioral experiments for forbidden foods. So often you will see with many patients with disordered eating and eating disorders is that they will not eat certain foods. So they will not eat carbohydrates, they will not eat cakes, pizzas, or cheese because there's a fear. If I eat certain foods, again, I will absolutely balloon. My weight will gain uncontrollably and my body will change rapidly again. And this is why it's really important that we do some behavioral experiments around this. So let's say, for example, the belief is if I eat a slice of cake, I will become fat overnight, none of my clothes will fit, and I will put on 20 kg. And this is, we go into behavioral experiments that actually the actual weight gain was not what I predicted. And of course, it has not changed my clothes size as such. So this is really important that we do this in phase 2, the behavioral experiment for forbidden foods, because without this, the patient will only eat their selected food and will not develop the flexibility that you can eat other foods from time to time as well. And of course, it's also the demonstration. If you eat a certain food, it doesn't mean you will lose control as well. So this is why the behavioral experiment is really, really important. So this is how you've probably seen this in other interventions with other forms of disorders, doing the behavioral experiments, of course, establish the current belief, rate the strength of the belief, and then actually introduce the theory A or theory B, agree to a time frame. So when in the case, in the role play, I was trying to be as specific as possible in terms of ensuring you have a time, place, look at the barriers that may come up so you can address that in the session, assess the outcome of which belief was right in the next session, and then see how this can be applied to other foods as well, which the person may have been avoiding, and how to continue to do the behavioral experiments with other foods as well. So just for examples, over here, if I eat 2 slices of bread at every meal, my weight will go up by 3 kilos in a week. Alternative belief is maybe the bread will not make my weight to go up at all. But the belief in the increasing 3 kilos is 100%. I 100% believe this is true, whereas the alternative belief is only 5%. So the possible methods is, of course, eat the bread. And what I like to do, just to make sure the client is doing this, ask them to eat in the session, because obviously they may have some safety behaviors at home. So often it's helpful, to ask the client to bring the food with them so they can eat it in the session with you rather than eating it at home. And then, of course, we can do the behavioral experiment and share this with the client. It's really important that we do it together and collaboratively. So some principles, because all this work that we are doing is grounded in inhibitory learning. And this is really important, that we need to maximize and generalize the learning. So for example, when they start learning just by eating bread, I will not put on weight. We need to start generalizing the learning to other foods. So, okay, that's been your fear. So this is why you haven't been eating carbohydrates and bread. How can you now start introducing other foods in your diet as well? So for example, if a patient is afraid that chocolate will make them gain weight, and that opening a pack of biscuits will mean that they binge. And once we start realizing this is not true, we need to start applying this principle to all other foods as well. Often this may sound quite challenging, but once you are over this hurdle with your patient, it's really quite easy. The next steps are really, really easy, because the patient is learning that food does not mean that I will gain rapid amount of work. So before we move on to phase 3, any questions so far? No. So again, it's really important that you stay focused at this point, and that you remain weighing the patient and keeping the diaries as well. So it's really important you remember as a therapist that you're setting this up. I've got a question through, sorry. How do we deal with people with binge eating who eat with the fear that they are not going to get food again, so they can't stop themselves and keep eating in that moment, even though they're already full again? So the fear is that they may not eat again. So because of that fear, they eat as much as possible. Again, really thinking about this, thinking about that fear that they will not eat again. Does that mean they purposely will stop themselves from eating again, or will they just not have access to the food? Sorry, Sadia, could you just clarify that for me? So do they mean that they purposely will restrict their diet so they do not eat again, or does it mean that they will simply just not have access to food again? But I'll come back to that for you. So phase 3, working with emotional triggers to eating behavior. So this is really, really important, because often we see many people who are emotional eaters or restrict their food for emotional reasons. So if I've been feeling down, depressed, or hopeless, I will not eat. Or sometimes I've had an extremely stressful day at work, so they will start binge eating. So this is looking at the emotional factors which have been driving the eating behaviors. So at this stage, only do it if needed, because not all people are emotional eaters. So you may not need to do this phase. You may just need to continue with the exposure and then the nutrition and weighing oneself. But do this if needed. And if you see clear links between the emotional factor being a trigger to the eating behavior as well. So the eating needs to be stable and adequate. So at this stage, they probably have been engaging in the nutrition exposure, they've been weighing themselves, they're eating a bit more as well. Because like I said, the emotions will not stabilize unless they are eating some decent amount of food. So this is why the next stage will only be effective if they've conquered the first stage. So the eating needs to be stable and adequate. Does the story add up if the patient says they're eating adequately and binging, but their weight is still not increasing? So often that will be a factor for you as a therapist to explore this. So for example, if the client is saying, yes, I'm eating 3 to 4 times a day, but there's still no weight gain, then you need to question that and you need to explore that, because that's extremely common, which I see in some of my patients, and I need to question if they are honestly eating as much as they are saying. So psychoeducation is a really good start at this point, looking at the functional value of emotions and explaining the value of emotions and how they impact your behaviors. So again, going back to the CBT model of thoughts, feelings, behaviors, problems when we try to block or avoid the experiences of emotions. So often people may restrict their food or binge because they're avoiding a difficult emotion. So in response to that emotion, they will restrict their food or binge, of course. It can be compulsive or impulsive. So compulsive are often the restrictive or compulsively exercising, and the impulsive is when I've impulsively felt that emotion, I've been binging. The impact of childhood emotional invalidation, and this is where some of the DBT skills will come handy, and the relevance of emotional inhibition core beliefs that follow. So what that basically means is often we have made many negative core beliefs about ourselves from early childhood experiences. And due to those negative core beliefs, we have started engaging in these unhealthy eating behaviors. So this is why it's really important, again, to address the core emotion at this stage, not before. It's now that the stable eating behaviors have been established, we can start addressing the emotional eating side of things. So how do we do this? Just like we would do with any trauma-focused intervention or any other emotional-based intervention when we're working with CBT. So we look at the trigger event, the core belief that this has triggered the emotion, and then binges to block the emotion. So I have a case study here for you. I will just do share screen. 1 second. Which will show this in action, hopefully. Can you all see the Word document? If someone could just drop a message in.
Yes.
Yeah, fantastic. Thank you so much. So this case study, this was a patient I was actually working with recently, 18-year-old male. I've just changed his name over here to Junaid, suffering from patterns of disordered eating since the age of 14. His eating behaviors have fluctuated between restrictive to binge eating and occasionally purging as well and vomiting. He is attending college full time, reports chronic low mood, high levels of anxiety, feeling very fatigued and withdrawn. Cognitions are I'm fat, ugly. Others notice my stomach. He's very unhappy with his body image as well. People are much more better looking, in good shape. So of course, doing a lot of comparison as well. And I feel inferior and not good enough as well. Quite a difficult upbringing. Father was violent and abusive to him and his mum and his other siblings as well. And whenever he underachieved in school, unfortunately, his father would beat him quite badly. So simple 5-area model we did with Junaid is that the thoughts were, so what I asked, I said, can you give me a recent experience, or maybe can you provide me with an experience in the last 5 days where you have binged and had a binging episode? So he told me that the trigger was memories of his father. He was experiencing or reliving some memories of his father being abusive towards him. That triggered some negative cognitions. I'm not good enough. I hate myself. So those were the core beliefs. It made him feel upset, down, distressed, anxious, and worried. Physically, he felt extremely tense and sickly. So his behavior was to binge to manage that emotion and memory. And of course, after the binging, he felt even sick and even worse about himself and even disgusted about himself. And therefore the vicious cycle continued, because after the binge, he felt awful. He felt guilty for binging as well. And then he restricted his diet. So this is why it's really important at this phase now, in phase 2, that we start working with the emotions and we start working with processing the emotions as to what can trigger the binge. So in these couple of sessions, only 2 sessions, maximum 3 sessions, we will spend time focusing on the emotional factors. And Occam's razor, this is a theory some people may have come across. It's just using simple reasons why you feel like this. So often as therapists, we have this tendency to dig into early life experiences, look at attachment styles, look at developmental history. And often in some situations that can be helpful for you as a therapist to formulate and discuss maybe as a team, but with the patient, often it's not that helpful because you're not providing them with a useful, straightforward response that they need. So this is why it can be simple. So I just did the simple 5-area model with Junaid rather than doing the full case conceptualization or a longitudinal model. So identify the behavior and an incompatible behavior. So currently, if they feel sad, they will vomit rather than engaging in a helpful behavior, which is going out or calling a friend. Raise awareness of triggers when the behavior is likely. So again, using some sort of diary function, what may trigger you, what may bring back these certain feelings or memories. Plan to use an alternative behavior when the urge is experienced, to experience. And when using the alternative behavior, note the reduction in the urge to use the target behavior. So again, really getting the client to monitor their behaviors, explore alternative behaviors. So when you're feeling sad and upset, instead of maybe turning to food, what's a helpful techniques? What's an alternative way of coping and using that coping? And often what will happen, use the 2 to 5 minute rule. So say to the client, even though you may not like this, go for a walk, go speak to your friends just for 2 minutes. And you always say to them, not more than 2 minutes, not less than 2 minutes, because often what will happen, they will start off with 2 minutes and then continue with their walk because they're starting to enjoy it, right? So I always use the 2-minute model, and that was created by Podesky, I believe, the 2-minute rule, that you only say to the client, try the alternative coping technique for 2 minutes only. And often they will start seeing the results of that 2 minutes and continue engaging in the alternative behavior. Because so far, what the client may have learned is the only way I can manage my emotions is by binging or restricting. So we need to change that connection between that emotion and that behavior. So we need to start introducing that you can effectively manage your negative emotions by different behaviors as well. So sometimes, and this is where exposure therapy will be helpful, and then going back to your traditional CBT techniques as well, they may be using binging behaviors or restricting their food because they feel anxiety and they can't tolerate the anxiety. So to overcome that stress and anxiety, they will eat and binge. So again, using exposure therapy to sit with the emotion, tolerate the emotion as well. And the more you sit and tolerate the emotions, you can then overcome the emotion. And if you overcome the trigger, you won't have the need to binge or, of course, use those kind of unhelpful behaviors then. So it's really important to sit with the emotion. And I personally wouldn't use maybe mindfulness or self-compassion, because that can become a distraction then. You need to really sit with that difficult emotion, feel that difficult emotion with the patient, and allow them to tolerate that difficult emotion. And the more you do that, the more helpful it will become then. And then, of course, looking at core beliefs and very difficult beliefs as well. And at this point, you can do some history gathering with the patient as well, looking at where the anger comes from, whether this is from early life experience or with the parents, looking at the parents, the family's attitude towards eating as well, and using imagery rescripting. So if there has been a traumatic event early in the life, going back and doing the processing work, just like you would do maybe with the Ehlers and Clark's model, this is where you start addressing the depression, anxiety, and the trauma. But in the background, always remember you're continuing with increasing the nutritional intake. That's really, really important that that continues in the background, because without that, it will not work. None of this will work. So often I see many patients who have suffered some sort of trauma, and this is why later on they've developed an eating disorder. So often in the trauma, they may have experienced a sense of being vulnerable or out of control, and the food has become a way of maintaining the element of control. And this is why we have to go back in the memories, restructure the memories, process the memories as well. And this will help you change their attitude and relationship with food as well. But remember, this comes after you've done the exposure work with the food. Otherwise, this will not work. Any questions or reflections on this so far at all?
Sir, I want to say
Yes,
one thing.
of course.
Thank you for allowing me.
Most
Uh,
welcome.
like there are many individual differences.
Yes.
Some people they are not good in at exposure. Some people they lack skills. So we have to train them for the social skills. We have to train them for evidence gathering, for challenging different thoughts, for finding out the core beliefs. So and what do you say? We cannot follow it accordingly in the 10 session. Sometimes we need individual sessions in very detail, and that could be 3 sessions, 2 sessions. Then if such happens, then will we count those 2, 3 individual sessions in the 10 sessions of CBT you are delivering at this time? What we can do? Thank you.
No, most well, I think this is such an important question, and thank you so much, because they stress this being a 10 session model. However, from my experience from some patients, you are absolutely correct. I have needed more sessions. And that's usually at this point when I'm doing the trauma processing or looking at difficult emotions and managing, or could be social skills, because looking at there might be social anxiety work that we've needed to. So I would contract that, okay, I'm going to add only 2 more sessions, and contract and make this clear to the client that maybe 2 more sessions are needed, because you are allowed to be flexible as well in this model. So if there's good evidence, if there is a good rationale, and you can see the improvements, please do add more sessions and count them in the overall session. So you may say, okay, we plan to do 10. However, I can see that there would be some value in doing some more work on this particular area. Please do add more sessions as well. That's perfectly fine. I think it's really important that we be flexible, we be adaptive, and meet the needs of the individual. And again, it's looking at the client benefiting as much as possible from this therapy, so they don't have to come back for more therapy as well. So yes, please do add more sessions if you can see the value in this. It's really important that we do this. So what have we done so far? We've looked at breaking the link between the fear of eating and gaining weight. We've then looked at the emotional triggers and maybe some of the psychological reasons behind the eating behaviors. And then phase 4, we start working with the body image and the negative body image. And this is where, again, you use all your traditional CBT techniques, your psychoeducation, your imagery description, behavioral experiments, surveys, and exposure. And this is where we start looking at unhelpful behaviors, safety behaviors, excessive check-in, maybe checking my weight throughout the day, every day, checking my body, checking in the mirror excessively. And this is where we start looking at these behaviors, how helpful are these behaviors, and how we can drop some of these behaviors or start some of the behaviors as well. So Phase 4 is specifically working with body image, and often there is an overestimation of how the person may look. So I'm just thinking of Shaida's patient, which you mentioned at the beginning of the session, that you can see visibly she's absolutely thin, she's absolutely skinny, but of course in her eyes she might be quite fat, she might be quite chubby, and she might be putting on weight. And this is where we start working with the body image, sessions 5 to 9. So again, only do this if necessary. If the body image that was poor at the start might not be later on, so it may have improved, because with the nutrition it improves anyway. But if it is an ongoing problem, you can usually tell by key information in the ED15. So the ED15 does ask about attitudes towards body image. So you can pick that up from the questionnaire as well in that process. So now we are looking at the addressing over evaluation of weight and shape, and looking at some of the behaviors which are maintaining the over evaluation of weight and shape. So really attend to the factors that cause the problem. So we need to start attending to that, and often looks like a therapist delusion when we think that we can work that out in a meaningful way. So what I mean by that is that the client may think you're absolutely delusional. So you're actually thinking you're extremely thin, you're extremely skinny, but the patient will not believe any of this, and they will think you're the delusional one, or you're just trying to please them. So this is why we start looking this in a very objective and scientific way. So linking treatment to pathology, of course, the ignorance around the eating that will work with the psychoeducation, misperception, body checking behavior experiments, mind reading the survey. So we get a lot of the comparison that what people might be thinking about me, how other people look and how I look. Other people look better, other people on social media look better as well. So surveys will help with this. And body avoidance, do the exposure work by looking in the mirror and showing the patient the mirror, a full body length mirror. I will talk about this in more detail in just a moment. So some specific tasks which you can carry out at this stage is looking at addressing the mind reading. So others will think I'm fat, others will think I'm disgusting, other people will think I'm gaining weight. So your mind reading, how do we test this? How do we know this is actually true? Body checking, they may be excessively checking their body or not checking their body at all. Body comparison, who are you actually comparing your body with? Are you comparing your body with people on social media who are absolutely tiny frames, an absolutely ideal body type, or body avoidance? They do not like looking at their body. So often I have many patients who just hate looking at their body. So you will notice in many people with disordered eating or eating disorders, they tend to wear very baggy clothes, because they hate having quite well-fitted clothes, because they don't like their body shape. So they might be avoiding wearing certain clothes as well. And often they might avoid wearing, like for example, Shaida mentioned in the beginning, the client is avoiding wearing shalwar kameez. So there will be some sort of reason or rationale behind that, which we'll have to find out. And of course, engage in CBT with all this. It's really important that you do it in a very structured way and do homework settings. So for example, if they're not wearing certain clothes, get them to start wearing certain clothes. Are the fears tested, and do it in a very behavioral experiment way? Are they weighing themselves every day? What function does the weighing have? Can they reduce the weighing every day, or can they start weighing themselves weekly? Which one will be more helpful? If they are checking their body every day, how do we reduce this as well? Mind reading is really helpful when working with body image. I've done this many times by taking a photo of a patient. So I'll take a photo of a patient, and then we'll send it out in a survey in terms of some of the questions on the survey will be, what do you notice about this patient? How good looking is this patient or person? What are the main features? But I ask for the patient's predictions first. So the patient will always predict, the other person will think I'm fat, ugly, they will notice my chubbiness, and then they're really surprised when they have the results back. So this is why doing the surveys is often really, really useful when working with 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 the mind reading, of course. And check-in and comparison behaviors can be addressed using behavioral experiments as well, but doing it separately, which can really, really be helpful. Avoidance is usually best addressed using mirror exposure. So in the actual clinic where you are seeing the patient, try to get a full length mirror where they can see their entire body. They may have been avoiding seeing themselves in a full length mirror, and ask them to see themselves with no safety behaviors at all. So a safety behavior in that occasion might be, and you need to be careful when you do this, is they may have been wearing really baggy, loose clothing. To get them to wear clothing that is appropriate for their size. Often they may become quite distressed initially, but that will come down. That distress will come down. And just like in exposure therapy, you'll reach a stage of habituation where they will start getting comfortable seeing themselves in the mirror. So it's often really, really useful and helpful to do this live in the session with you. Just like eating live in the session with you, usually really, really helpful rather than them doing it alone at home with by themselves. And you can use graded exposure if needed, but I prefer going straight into it and allowing the client to see themselves in the full with the mirror there. And like I mentioned before, working with the emotions as well, addressing hurtful memories related to the emotions, and there will be some safety behaviors if there's been negative events in the past as well. Yeah, just doing the imagery scripting. Any questions around the imaging rescripting so far at all, or any difficulties anybody have had when doing this?
As you mentioned about that we have a mirror in the therapy room. Since we are working in the hospital, so if the mirror is not there, is it possible that we can ask you to visualize?
So sorry, Shah, I'm really struggling to hear you. I can't hear you properly. Sorry.
I'm saying, for example, in our clinic, there is no mirror, still mirror in the hospital room. So what can you do? Is it possible that I can ask my clients to close your eyes and just visualize yourself that you are standing in front of mirror and visualizing to see that? Can you do such a perform that exercise in this way?
I
And
I was struggling. Did you say that if there's no mirror available? I couldn't hear properly. Sorry.
exactly. There is no mirror available in the room.
Mm-hmm.
And if we want to do the same exercise, the mirror one, then I ask my clients to close your eyes and visualize yourself that you are standing in front of mirror.
Okay. So if there's no mirror available, you then ask your client to close their eyes, and if they can visualize themselves, is that right?
Yes, exactly.
Yeah. Okay. So let's just think about that for a second. If they are left with their own visualization and their own imagination, what do you think could potentially happen here? What could be a potential setback? So one of the problems with that is because they are using their own imagination, they are going to, again, over predict and make unhelpful visual expressions of how they actually look in reality. So I would not recommend that, because the problem is you're just allowing the patient to use their own thoughts. And we already know their thoughts are fueled with anxiety and negative core beliefs. So unfortunately, that wouldn't be particularly helpful in this situation. And this is why, just like weighing themselves, we need mirrors to make sure it's absolutely accurate on objective. So even if there's no mirror in the actual clinic room,
Even a small mirror is there. Small,
yeah,
like maybe
use a
1
small
pixel.
mirror. or using the camera on your phone as well. You can use that. But yeah, just asking them to imagine it is usually difficult because they will always imagine the worst and they will always predict the worst as well. So that's why it can be difficult. Really good question. How would we convince the client to take this step of letting their picture to be taken for a survey? Because absolutely, I think that's really good question. Thank you for asking this, because that can be a safety behavior that they never have their picture taken. Because the fear is, of course, if they have their picture taken, they'll realize how bad they look and people will start looking at them and predicting the worst and assuming the worst. So again, I would draw the 5 areas model, demonstrate by not having the picture taken, it's maintaining that vicious belief and fueling the belief. And if we were to break that cycle, just using the 5 areas model, what benefit that will bring in terms of actually, if I do allow others to see that picture or allow my picture to be taken, I can start breaking that belief and changing the belief that maybe there's something alternative, or is it as accurate as I think it is as well. So again, doing some motivational interviewing, cost benefit analysis, but using the formulation. The formulation is really important, and the 5 areas model is really important here, because otherwise you can demonstrate, if you just continue to avoid taking your picture, that belief will remain. How helpful is that belief? And this will really help with imagery rescripting as well. So before, actually, I will tackle this point in thank you. Can the client choose who views the picture? Yes. I think to protect their confidentiality and their integrity, they can choose. However, there's 2 problems with this. So I've had this problem with a patient that they said, I will only show it to people I know. Think of this like scientific research. If you were to conduct scientific research with only certain samples, your sample will be biased and your results will be biased. And therefore, if the client only sends the picture to their best friends or people they know, their family, the client will then say, of course, they have to say nice things about me because they're my friends or they're my family. So this is why I often say allowing strangers to see it in a confidential way is much more helpful, because they are not connected to that patient, and then therefore they can provide an objective view. And often what I tell my patient, I am only going to show it to professionals in the clinic or people like workers in the clinic or in the university, just to settle their anxieties that it remains absolutely confidential. But I wouldn't show it to selective people who the patient chooses. The reason for that is it will create much more bias. I'm really conscious of time, but I really want to do the rescripting exercise, because this will just help put this into perspective much more better and help demonstrate some of the safety behaviors we have as well. So if I could please have a volunteer, I can do the rescripting exercise with them, and then inshallah we can show this how we put this into practice with your diaries, with your weighing and your relationship with food as well. So I'm going to ask for a male. There's probably no male, but anybody, any female who's willing to do the patient role play with me, and then inshallah we can have yeah, I'll try my best to finish on time. But if yes, any volunteer, I greatly appreciate this. Of course, Mariam, more than welcome.
Assalamualaikum. Am I audible?
Walaikum salam. I can hear you, Mariam, so that's perfect. And thank you so much for volunteering. So in the rescripting exercise, similar to the case study of Junaid, what we're going to talk about is you're the patient, and we're going to access some of your early life memories where we will pretend that the father, your father's been extremely abusive. There's high standards, high expectations. You have to get the best grades, right?
Okay.
And we're going to just talk about those experiences and just explore those experiences. And then I will do the rescripting with you, inshallah. So, Mariam, thank you very much for coming back to session 7. as agreed in this session today, we're going to look at some of those early life experiences you've talked about. And I know you've been eager to talk about these experiences as well, because most of the sessions so far have been focusing on increasing your diet intake. And I think it's absolutely fantastic, the progress you've made so far, which is absolutely brilliant. And hopefully we can maintain this progress. But I know you have been eager to look at some of these difficult memories and emotions that have been coming up. So is that okay in this session if we
Okay.
focus on this now?
Sure. So I remember it was always really stressful ensuring that I'd perform well in my education. Uh, it was very stressful because there was always this concept at home that I had to really work really hard to ensure that I get a really good job and be someone that can earn and take care of the family. And that was very stressful. And my father used to belittle me at the slightest of mistakes. And I couldn't accept any forms of failure. And it just always used to be very stressful before exams, during exams, managing that. And it just never, I could never get past that.
Yes.
And looking back at that, I feel that I feel like the pressure was just unnecessary, given the fact that, I mean, something so simple as failing or not getting the best grades to determine my entire future is, it just seems very irrational. So at this point, I feel like maybe we can, I feel at this point that to some extent I've managed that anxiety regarding, because it's not just the anxiety with exams now, it's just like everything, every little failure would affect me on some level. So at this point, I feel like to some extent I've managed that, but obviously it's something in the past that has caused a lot of harm to where I am at the moment, especially as well with my eating habits and all of that.
Yeah. Thank you. Thank you so much for sharing that with me, Mariam. That sounds really difficult. And I appreciate and respect you for sharing that. And it sounds like you said, you've managed it to some extent, but it still impacts you, the harm. Would that be fair to say?
Definitely, yeah.
Definitely. Okay. Would it be okay if we could maybe think of a particular memory that really sticks out in your mind when talking about this? Like you said, there was many stressful situations, many occasions where these difficulties occurred. Can you take me back to a particular time that stands out for you in your mind?
I think when, there was a lot of pressure on me to become a doctor. And so when those exams came by, they expected me to get the highest grade. And they were really, and I just barely managed to pass. Because studying for medicine is not an easy thing at all. And given that and all the pressures around me, and I don't think I was eating well enough either to help support that workload. I didn't manage that really well, and I came home and it just didn't go as planned. And so there were just a lot of factors that really put me down. And the worst part was that I couldn't even come back home to a safe space because it was just consequence after consequence given the situation. So that would be one memory, I guess.
Thank you. No, that sounds really, really difficult. But again, thank you so much for sharing that with me. And like you said, the worst part was that you couldn't come back to a safe place. So can you just talk me through that day when things did not come back and you came back home? Can you remember what your father said to you?
Well, he said that that I just haven't ever met up to his standards, and I'm just a disappointment. I'm a waste of space. I am unable, like, I wasn't able to meet his expectations.
Yeah.
And it felt like I didn't have anything that I could have achieved later on as well. So that's really what I can say on that.
Thank you. So again,
It was
really,
just a dreadful day altogether.
yeah, it sounds dreadful. It sounds really challenging. So your father made these comments that that you did not meet his expectations or live up to expectations. Can you remember how you felt at that point in time?
Disappointed in myself.
Okay.
With, I guess you could say, I didn't see myself going anywhere after that.
Mhm.
Everything just felt like it was collapsing.
Just collapsing. Yeah. And can you visualize how you saw yourself at that moment in time? Can you see how you were standing, how you saw yourself maybe?
It felt like it felt like he's tiny and I just felt, or that's how I experienced it.
Okay. Sorry, I missed a bit of that, but I heard
Sorry.
that you felt very tiny and that's how you experienced it. Sorry.
Yes, like
Yeah.
yeah, it was just like the earth could have swallowed me whole.
Okay.
I wanted to hide. Yeah, I felt really tiny.
And now, in the here and now, when you feel or have the same emotions now where you feel disappointed in yourself or feel tiny, how do you deal with that in the here and now?
I've realized that life is definitely much bigger than the expectations that people have of
Okay.
us overall. And we can just try our best, or I can just try my best at what I can do. And whatever I am able to control, that is my focus. And then the rest is just, it is what it is, basically.
So it sounds like you'd be more compassionate, like with yourself now, and you've got that understanding
Yes,
now.
definitely.
So if you were to go back in time, Maria, but as an adult, like you just talking to me now, yeah, you can see the bigger picture. You can see we can't always live up to people's expectations. If you could just close your eyes and imagine you as an adult are going back to child Mariam, the child in that room where the father's kind of shouting at you and saying these horrible things to you.
Mm-hmm.
What would you say to that child, Mariam, as an adult?
I would say that that the world is much more bigger than just this moment, and there's so much more to experience and understand.
Mm-hmm.
I guess give more importance to the things that require more depth, like the things that would really require that level of importance from me as a person. That's, I guess, what I would tell my younger self.
You tell you, and what would you be saying to your father as an adult if you're
I
back
would be
in that
saying,
room?
that because now that I've grown up and I've understood how difficult it is being a man in the world and earning and supporting, I can understand, I can compassionately or empathize with his level of stress, maybe that he experienced or perhaps he had gone through. And I can't change much of how he believes the world will work, but I can definitely let him know that it's okay.
Yeah.
And that he has his own space and I won't hold him accountable for how things turned out.
Brilliant. Okay. So it sounds like you'd be compassionate to yourself as a child more, supporting yourself more, and then trying to empathize with your father a bit more. Is that right?
Yeah.
Okay. How are you feeling right now?
I'm feeling quite well.
Quite well. Okay. So let's think about this, Mariam. You talked about being compassionate, thinking of the bigger picture and being nicer to yourself. So when you feel down now and you stop eating and you keep yourself hungry and you starve yourself, what would you say to yourself now in those situations?
Well, I mean, I have identified, I mean, especially after coming and, you know, seeking your assistance, I realized that definitely this behavior is not the best. I'm working towards rectifying it, and there would be some days where it won't always be the best, but I feel that it can take a while for me to get back into eating regularly and taking care of myself from that aspect. I think the good point would be that I've identified that it's not the best response to my feelings. And as long as I'm trying to at least take one step forward instead of 3 steps back, it's good progress.
Good progress. Fantastic. So it sounds like even in the here and now, when you try starving yourself, it's like you motivated, right? You want to make those changes and be, again, nicer to yourself. Is that right?
Yes.
Yeah. So one of the things you told me in the session, because of this really difficult experience with your father, you avoid looking at yourself. You don't like looking at yourself, again, because that brings up the feelings of disappointment.
Yeah. It does.
So, okay. So if we were to look in the mirror now, think about what you just said to the child, Mariam, as a Mariam. What would you say to yourself when you're looking in the mirror now then?
I think telling my child, the younger version of myself is relatively, even though it sounds strange, but it's relatively easier.
Yep.
But when I look at myself in the mirror, it takes longer, slightly longer for me to be compassionate with myself in the mirror, I guess you could say.
And that makes sense. That's understandable. As an adult, it takes us time to be more compassionate. Can we start practicing this? So, and as you know from the previous sessions, the more we do something, the easier it becomes. So can we start practicing looking in the mirror so it takes less time then?
Definitely, we can try that. Although it would be a bit difficult, but I'm open to trying.
Good. I think that's the main part. We need to hold on there. We're open to trying. And this is all about being open to try.
Definitely. Fantastic.
Thank you so much, Mariam.
Thank you.
Cannot express enough my gratitude to you right now for helping me with that. I know we're really short on time, but really quickly, any reflections or feedback from anyone in the, and please be honest, like I said, absolute psychological safety here, no judgment. You can you can criticize me, it's perfectly fine. But anything you found helpful or not so helpful as well, it would be really good to hear from the group.
So that was really nice. Sorry, somebody else was speaking.
So was that
No,
Mohammed?
okay. Please go ahead.
Yes. Yes, thank you very much. First of all, I feel sorry because I was too busy. I was unable to be the participant.
No, okay.
I'm really very sorry. It was really a wonderful exercise. I have gone through such feelings because I have gone through the one of the PTT, I think, RTT exercise. And
Right.
it's really wonderful. And I have gone through this feelings of being a young guy and how to behave. When I gone through this feeling, I just hug that guy to give them feelings of being secured, that somebody is around him to hug you, to take care of you. It's really wonderful. I really like it because I have gone through this second time and it's really helped me a lot. And it really makes different for the people who gone through these feelings or the way you have gone do this process. It was excellent, wonderful. Thank you very much.
Thank you so much. Thank you for speaking as well, Mohammed. We needed a male in the group, so absolutely fantastic. No, I really appreciate. No. I really appreciate this, and I really appreciate you've tried this, so you know the power of this as well. And I think this is why this comes later on in the protocol, because because unless you've not established stability with the nutrition and the increase in diet, it's not going to work, because the client will remain unstable. Thank you so much for that. And Asma, sorry, I think you had your hand up.
Yes, thank you so much for the wonderful presentation and the skills that you have demonstrated. I'm just going to bring forth my own difficulty in therapy, that sometimes the clients are doing very well in the sessions, but they have difficulty in translating this into real life. So I'm just going to ask about your experience, the behavioral experiments, the working with the core belief. They're good in bringing the extensive thought diaries and everything, all the steps.
Yes.
That's my question.
No, thank you so much, Asma. That's a really, really good question about implementation. Inshallah, what I will do, I'll just finish the presentation. There's not much to go, and then I'll come back to that, because I think that's really important. We look at this in terms of maintaining and implementing it outside the therapy room in different areas of a person's life as well. So I'll just quickly do share screen, and then just going back to addressing body checking and comparison. Again, looking at either increasing this or reducing this, it's really very important, because there's a lot of safety behaviors in this which maintain some of the difficulties which the client are experiencing. So 1 week of using check-in comparison behavior as often as possible, and then in the second week you drop everything. So what's really interesting here, I actually encourage, because the patient often has a positive belief that check-in is helpful, making comparisons is really helpful. I need to check as much as I can, because that will reduce my anxiety. The irony is, by weighing themselves 3, 4, 5 times per week, it just makes them even more anxious. So what I often tell them is increase it. If you think it's such a great technique, which will help you increase it, and then they start realizing, actually, this behavior is not helpful. It's making me feel even more anxious rather than reducing my anxiety. So this is a really helpful way of first week doing an experiment where you increase check-in on comparison behaviors, to the second week where you completely reduce it or get rid of it altogether. And they often feel more sense of relief because they're not doing the check-in or the comparison as well. Often, just some few points as well. Sorry, check-in behaviors often it's natural. We all do this. It's perfectly normal. It's only when it becomes excessive that's when it becomes problematic. And also, social media, change the pattern, either reducing social media or turning it off altogether. And I guess we could have a full 3-hour session on the unhelpful and the side effects of excessive social media use. So I won't go into social media too much right now. Again, of course, I will send out all these slides again. I have included many helpful examples in here. And again, this is using examples from earlier as well. A participant mentioned this as well in terms of weighing themselves 3 to 4 times a day. Often weighing oneself has this, it's like magical thinking, almost just like we have in depression or anxiety-based disorders. Somehow there's again, this is the anxiety driving this belief that if I weigh myself, I can control my weight. And in fact, actual fact, we know that's not true. So again, it's testing the client's belief and then allowing them to look at more healthier ways of managing themselves and managing their body image. So I won't go into this in too much detail. We've talked about full length mirror exposure, how this is beneficial as well, especially if the patient has been avoiding looking at themselves in the mirror. Initially extremely distressing and anxiety provoking, but it reduces, just like habituation, it reduces over in time. And now I will come to Asma's point in terms of maintaining progress, because this is really important in phase 5 in looking at relapse prevention. So attributing success to the patient. it's all about the patient, because the patient would have done all the work in these sessions. They would have increased their diet intake, they would have completed their diaries, they would have engaged in all the behavioral experiments and allowed themselves to be weighed as well. So lots and lots of positive reinforcement for the patient, and really being positive to all the progress that they have made in the sessions as well, because that will really help them maintain their motivation and keep them engaged. Review what has gone well and what has been challenging as well, because it's really important, that validation as well. And of course, create a therapy blueprint. And this comes back to Asma's point, and also a point I made very, very early in the session. It's thinking about therapy being 168 hours per week. So it's really stressing that therapy is just not this 1 hour in this room. CBT works effectively when you start applying all these changes, all these different interventions in different areas of their life. So one thing that I find really helpful, which I do with my patients, I will ask them to draw a bit of a pie chart with me and looking at their different areas. So there's personal life, there's social life, there's family life, there's work life, and then asking them, how can you implement some of these changes in the different areas of the pie chart, the different areas of their life, and then setting that as homework. So for example, you may have a person with eating disorder who does not eat with their colleagues at work. So how can we introduce that as a behavioral experiment or exposure work in their work life? So really helping them open up about their different areas of their life and think about different areas of their life and how to implement it. Always go back to the 168-hour equation, because that really helps the patient realize, I need to be implementing this every single hour in every single area of my life. Otherwise, again, it's not going to be helpful. And I think this is the difference between this particular protocol compared to other treatment interventions in CBT and other treatment protocols. With eating, you can't escape it. You know, your human body needs food, regardless of where you are. If you're on holiday, if you're in your house, if you're at work, if you're in the car, this is something we take our bodies, our stomach, our organs everywhere with us. And this is why it's really important. You stress that if you are going to do this treatment, it's looking at your life hour by hour, not just for the 1 hour you're in the room. So it's really important that you engage in this in all different areas of your life. So of course, really important to do the relapse prevention. The more thorough you do the relapse prevention, the less likely the setback will occur. I always explain to my patients the difference between a lapse and a relapse as well. It's really important that we think about that lapse. We all have a lapse. We all have a day where we might feel a bit down, where we may not be as active as we were, or we may eat more or less. That's perfectly fine. That's normal. This is human nature. We're not aiming for perfection, and that's the lapse. Whereas the relapse is, of course, if it's prolonged, if it's impacting, and it's lasting for a longer period of time. So I always stress this in relapse prevention. We all have lapses, which is perfectly normal. We all have the cheat days in our diets as well. That doesn't necessarily mean it leads to a full-on binge or leads to the old behaviors as well. So finish well with the patient, review everything that you've covered, really look at their strengths and skills, and have 2 follow-up sessions with the patient as well. The follow-up patients will allow you to look at slips and lapses, and the second follow-up will help you again positively reinforce the good work the client is doing, and how they can maintain this. So in terms of what we have learned here, be optimistic, but be prepared to work hard. So one of the difference between your traditional protocols in CBT compared to this one, you are much more firmer, you are much more assertive and much more directive. Whereas with other CBT protocols, you may have the guided discovery, the Socratic questioning. It's much more nicer, right? With this one, you're much more formal and much more direct as well. So it's slightly different, but be optimistic. It does work, and the evidence says it does work. Anxiety matters on both sides. So really, really engage in supervision, good supervision, where you are practicing the self-reflection, because your anxieties will definitely interfere with the anxieties in the therapy room and how the client is progressing as well. To be honest, there's no special technique. We're using all our standard CBT techniques, just done in a slightly different way. And yes, look for the early change, because if you make the early behavioral changes, your therapy is going to be more successful later on. And finally, give it a go and see how you get on. These are my contact details in case anyone needs it, but I will send out the slides, the questionnaires, the pack, and the thought diary, so you have a full pack. But please give it a shot. This is highly effective, highly helpful, and I'll also send out the research papers and the research data, which confirms that when done safely, this has been highly effective with people with disordered eating. So I will stop talking there. You're probably all sick of my voice by now. I just want to say thank you so much for listening for 3 hours, engaging, and thank you so much for the volunteers as well who did the role plays with me. I always like doing the role plays because it just makes it so much more meaningful and adds the value, and especially the clinical skills that is much needed. So I hope you have all gained something today. And like I said, please do contact me if you have any further questions or need supervisory support. More than happy to support you. And I'll send out the information pack as well. So inshallah, you all have that. I will stop talking. Any questions, more than happy to answer, but I will hand back to the host now, inshallah. Dr. Mirat Gol, you're here.
Assalamualaikum.
Walaikum salam. So nice to see you.
Yeah, same here. Thanks a lot. Really, it's an amazing workshop. I've been attending it, but unfortunately, I just reached around 7, so I couldn't start in time.
No
but I hope the participants have enjoyed it a lot and have learned a lot, because I have seen that you have started and demonstrated everything very structured, in a structured way. And most of our participants are the students of PACT diploma, CBT diploma. So they are habitual of that sort of structured information. And this is amazing that you are giving them this new topic, because we haven't covered it yet. And it's really important nowadays. It's all over the world, mostly not only the girls, but I think the adolescent, adolescents is very common.
Yeah.
So I'm really thankful, and I would like you to continue with PACT and giving us updates, and this journey which just began, we want to continue it. And apologies from my side and for this online workshop, because the issues which came up, and we have to surrender. But I was imagining if you were there and the workshop is like we are conducting this workshop in person, the participant must have enjoyed it a lot, because online they are engaging with you so much. So if it's in person, it will be more beneficial. But hopefully, inshallah, in future, we will be able to conduct it. Thank you.
Most welcome. Thank you so much for your kind words. Inshallah, I'm here to support you guys. Thank you for allowing me to do this on your platform. But inshallah, there's always tomorrow, so we can always plan this in person at some point in time, inshallah.
But we make sure this time that everything goes smoothly. Yeah.
We can't predict it. This is the problem.
This is Pakistan.
This is Pakistan.
Yes.
It happens.
Yeah. Thank you. Thank you. Thank you, everyone. Thank you for your
Most
participation.
welcome. Thank you so much. Thank you. Goodbye. Khuda Hafiz.